going to call to order this hearing of the Assembly Committee on Health and ask the members of the public to please take their seats. Just want to remind everyone that our usual rule will apply, which is 2 witnesses per side with a time limit of 3 minutes each, or a total of 6 minutes to a side to divide up as you see fit. Witnesses who testify after that, please state your name and organizational affiliation of the fact of your support or opposition only. On the consent calendar, we have one item proposed for consent, and that's item number 4, SB 241, Senator Runner's bill. And we don't have a quorum yet, but as soon as we do, we'll establish one. And if there's no objection, I'd like to suggest we proceed as essentially the subcommittee of the whole and take the bill of the first author who is signed in. And I take that back. We're doing it in file order. And so let's see. The first in file order, Senator Wright. Mr. Wright. Oh, okay. So apparently the senators have negotiated, and Senator Corbett's going to go first. Yes, of course. Senator Corbett, welcome.
Thank you very much, Senator Wright, for allowing me to go forward. Judiciary is being held right now, so I have to get back in chair. So thank you. And thank you, Mr. Chair and members. I'm here to present Senate Bill 196. This was presented last week, so I will be very brief. This is a bill that will allow for additional notice before an emergency room is closed. And by the way, I might add, Assemblymember Jones, Mr. Chair, I am, of course, taking the amendments that you suggested, which allow for the notice to be 120 days, allows that there be a notice of changed from 30 days to 60 days for the closure of an acute care hospital, and allows for notice to employees before there is a closure, and at least 3 public hearings to inform the public of the closure. The reason I'm doing this bill is that many of us, have situations where we may be facing hospital closures, and you know how important that is to your local community to keep those hospitals open. So this will allow additional time for the community to work together to see whether they can find a new operator, or maybe put together some sort of agreement between local hospitals to continue to fund that hospital, keep it open, and also keep the emergency room open. I also wanted to thank Assemblymember Hayashi. I had an opportunity to work with her and talk about this bill, and we have agreed that this is a very important measure and that we will continue to work together to fight to keep a local hospital open in our district, San Leandro Hospital. And I want to thank her for her courtesies that she has extended, and will continue to work with her. I just wanted to make one more comment, and that is, in looking at the analysis, I did want to point out that although there is a comment that it's very difficult to find a new operator during these economic times, in the case of San Leandro Hospital, there actually is a new operator that has come forward after the many public meetings that we have tried to have in that community, and it looks like they would be a suitable operator for San Leandro Hospital. We still have a few more steps to go, but it's looking positive, at least on that scale. Thank you very much, Mr. Chair, and I'd ask for your aye vote on this measure.
Thank you, Senator. Do you have some witnesses?
Yes, I do.
Mr. Chair, members, Deanna Furman on behalf of the California Nurses Association. We're in strong support of SB 196 because of the consistent pattern that California has witnessed of ED closures. Frequently, hospitals have been closing EDs or full hospitals because they're financial losers only give the community the minimum of the 90 days notice. And then this leaves communities in a lurch as they struggle with the lack of critical emergency care services. And SB 196, as amended, will simply increase the time a hospital must notice of an ED closure from 90 to 100 days and add employees to the list of entities that must be provided with this notice, and requires the hospital hold 3 public meetings. Closing or downgrading an emergency room is very hard on communities, and it's been a consistent pattern throughout the state. This bill would simply provide creative solutions and ways for communities to seek to keep it open or find a new provider, and we're really happy to be in strong support of SB 196.
Beth Capel on behalf of the Service Employees International Union. We represent hospital workers at hospitals in a number of the hospitals in the area, and that are affected by this bill, including one of the possible bidders on the hospital. This bill is an important bill for the reasons that CNA has already stated. Giving a little more time, giving a little more notice gives the community and those who want to see a hospital stay open the opportunity to find another potential bidder, and for that reason we're very much in support.
Thank you.
Brett Mechlin with California Medical Association, also in support, and we do appreciate the additional time to allow the medical staff to be able to work with the hospital in order to save as many hospitals as we can as we begin to lose more and more in the state. Thank you.
Any witnesses in opposition?
Good afternoon, Mr. Chair and members. Connie Delgado Alvarez with the California Hospital Association. We are here in opposition today. Members, California's hospitals find themselves in a very difficult position. We have to make difficult decisions sometimes in order to preserve an entire hospital. We have to sometimes make decisions to close or downgrade an emergency service. We believe that the current requirement of 90 days is adequate, and adding additional time on that will compound the financial situation of hospitals by requiring them to perhaps hire registry nurses or physicians to come in to care in the time that we believe that staff would leave after such a notice is given. We do the best to keep our doors open, and for those reasons, we are in opposition today. Thank you.
Thank you.
Catherine Austin Scott with United Hospital Association. I concur with the previous statements. Would only add we believe the 90 days is a good balance for maintaining staff levels while trying to work through the difficulties of the hospital. Thank you.
Mr. Chair, I believe you might have a quorum.
No, we actually need 10.
Paul's here.
Where is he? I can't see him.
You know what? I'm right here. My whole life I've been marked. I'm not that dark.
Someone tell Mr. Nava to stand up. Oh, sorry. Okay, we do have a quorum. Thank you, Senator. It's very helpful. Let's ask the Secretary to call the roll.
Jones.
Here.
Fletcher.
Here.
Adams. Amiano. Block. Carter. Conway. De La Torre. De Leon. Emerson.
Here.
Gaines.
Here.
Hall. Hayashi. Hernandez. Lowenthal. Nava. Perez. Salas.
It's okay.
Strickland.
Okay, quorum's established. We've heard from proponents. We've heard from opponents.
Mr.
If
Chairman,
the
I'd like to
committee
move
has
the
any
bill.
questions, there's a motion for Mr. Adams. Is there a second?
Thank you.
Ms. Carter, a second for Ms. Carter. Any discussion by members of the committee? We did have a significant amount of discussion last time. Would you like to close?
Yes, just very briefly. Thank you, Mr. Chair and members. This is a very important bill to my district. Our community has shown, and many communities throughout the state, with just a little additional time, there are opportunities to keep our hospitals open, and I'm hopeful for that in my district as well. I very much appreciate your aye vote.
Thank you very much. The motion is due pass as amended to appropriations. If there's no further discussion by members of the committee, we'll call the roll.
Jones.
Aye.
Jones, aye. Fletcher. No. Fletcher, no. Adams. Aye. Adams, aye. Amiano. Aye. Amiano, aye. Block. Carter. Carter, aye. Conway. De La Torre. De Leon. Emerson. Emerson, no. Gaines. Gaines, no. Hall. Hall, aye. Hayashi. Hernandez. Lowenthal. Nava.
Aye.
Nava, aye. Perez. Salas. Strickland. Strickland, no.
That is 6. It needs 4 more votes.
Thank you very much, members and Mr. Chair. Thank you very much.
Thank
And
you,
Mr. Wright,
Senator.
thank you.
So next we're going to call item number 1, SB 161, Senator Wright's measure.
Thank you, Mr.
Welcome,
Chair.
Senator.
How are you?
Very well. You?
Well, I'll be good if I can get enough votes to to get out of here this afternoon. But let me thank the committee for hearing this bill. As some of you may know, I am myself a cancer survivor. And what this bill seeks to do is to provide a playing field between orally administered drugs and intravenously administered drugs. The way going now of the technology in cancer treatment is to provide oral administered drugs. You know, there are a number of men and women who will probably die of cancer. I have witnesses here in support who've had various stages of dealing with the system. In short order, what this bill would do, Mr. Chair, is it would say that if a bill is orally administered, it would be treated in much the same way. One of the concerns, obviously, that someone has raised is that we did not include CalPERS. That would have probably made this bill more fiscal and in this environment that we're in. But I fully intend that CalPERS will comply with the statute. So I'm not as concerned about that because it does not preclude them from getting involved. It simply did not have them do it by statute. So that concern that was raised was not an effort to say that it was cost prohibitive. And the cost to the state would have been roughly $166,000, which would have gotten it, you know, potentially in PERS. So that was the reason for that. And I have witnesses in support.
Okay, why don't we hear from your witnesses?
Mr. Chairman, members of the Assembly Health Committee, my name is Jean Krim of Carrie's Touch, an organization dedicated to improving the lives of women with breast cancer. We are pleased to serve as a co-sponsor of Senate Bill 161 by Senator Roderick Wright, along with the American Cancer Society. The group of cancer patients that will benefit most by the passage of SB 161 is women with breast cancer. African American women have the highest death rate amongst women with breast cancer, even though they do not have the highest incidence of breast cancer among women. There are many factors which contribute to the high death rate among African American women with breast cancer, including barriers to treatment associated with the expensive out-of-pocket cost. Senate Bill 161 attempts to address this issue by decreasing the out-of-pocket cost for purchasing chemotherapy at the pharmacy counter. I will yield the remainder of my testimony to Jerry Carpentier, a cancer survivor who will tell you her story and why Senate Bill 161 is so desperately needed.
Thank you.
Members of the California Senate Assembly, good afternoon. My name is Jerry Carpentier, and I live in San Jose, California. I've been married 41 years. I'm the mother of 2, a grandmother of 1, and will be 60 years old in September. I am unemployed and on disability, and I am stressed. On January 12, 2009, I was faced with an emergency surgery for an intestinal blockage that turned out to be advanced colon cancer. Even after battling 2 previous forms of cancer with chemotherapy, Hodgkin's in '97 and lymphoma in 2003, I was unprepared for the stressful and unfortunate events that followed this most recent diagnosis. 10 days after the diagnosis and emergency surgery, I returned to the doctor's office to have the staples removed and was informed that my body was now fighting a wound infection. Unfortunately, this meant I could not start chemotherapy until I was completely healed. I also needed to get approval to get a wound vac from my insurance company to expedite the healing process. During this time, my cancer was left on its own to spread. It took 3 entire weeks to get the approval from my insurance company for the pump and an additional 5 or 6 weeks for the wound to finally heal. All that time was critical in getting my chemotherapy. After over 6 weeks of high anxiety, I finally received notice from my surgeon that I was ready to start my chemotherapy treatment and was scheduled to begin 4 days later. Having been on IV chemotherapy previously and diagnosed also with congestive heart failure from the chemo, I was extremely hesitant to begin treatment. When the nurse told me that I was prescribed the oral form Xeloda, which is generally more tolerable than the intravenous form, I was ecstatic. With generally less toxicity and fewer visits to the hospital, I knew this would give me more energy to help me battle my cancer. On Friday at 5 p.m., before the treatment was scheduled to begin, I received the dreaded phone call notifying me that my insurance company would not approve the pill form of Xeloda. This meant I would be charged $2,000 out of pocket for a 14-day supply. I needed a 28-day supply, or $4,000 a month copay for the pill. As I was not able to afford this high expense and was in urgent need of starting my chemo, I had nowhere to turn but the IV version. Any drug was better than none at this point. Exhausted and scared as I left my cancer untreated, I was then told by my insurance company I would have to wait yet another week to get approval for the IV version of treatment. In that period of time, I had a PET scan and showed that the cancer had metastasized to the other side, a potentially deadly event that could have been avoided if I was able to start my chemotherapy earlier. My alternative to the hefty $2,000 for the $2,000 for the oral chemotherapy was every week left me with a liquid form infused through a pump for 46 hours at a time. Every other week, I'm required to receive 6 hours of infusion plus go home with the pump. I have to tell you, there's nothing like sitting there listening to the pump ticking and chemo being injected into my veins. During my third round of chemotherapy, I was confronted with a situation like a nightmare. As I lay down to go to bed, the alarm on my chemo pump began to sound. The chemo pump was leaking substance that was so toxic it had turned the black drainage bag white. Shocked and scared, I immediately headed to the emergency room at Stanford, pump in a plastic bag and wrapped in a towel, where I was rushed to the back and the pump was disconnected and my portal flushed. I'm scheduled to have many more rounds of IV chemotherapy through the rest of the year, and I feel I'm justified in saying I'm scared. I'm scared of what might happen if I'm once again injected with this toxic substance, and all the while sitting at home without a healthcare professional's supervision. If only my insurance had offered more assistance with the oral chemotherapy, I would have been able to afford this alternative treatment, and I would not be in this position today. I would not be fearful for my safety, and I would not be sacrificing the days of my life while I sit at home receiving IV treatment. I strongly urge you to support Senate Bill 161, which would require health service plan contracts and health insurance policies to treat orally administered chemotherapy. Okay.
Okay, we just have to ask the other witnesses if you can just identify yourselves and your organization, the fact of your support.
Thank you, Mr. Chairperson, committee members. My name is Sid Scudder, and I'm a medical oncologist. I work at UC Davis. I'm director of the infusion room there, and I'm here in support of AB 161. As many of you know, some of us are old enough here to remember in 1971 when Richard Nixon declared the war on cancer. And over the last 50 years, that war has resulted in a tremendous amount of research, and that research has made significant strides in the treatment of cancer. In the last decade, we have become much more specific, and the drugs are less toxic, and many of them are oral. Over the course of the next 10 to 15 years, we expect the number of oral drugs to increase significantly. The co-pays for these oral drugs based on pharmacy benefit is substantial. The cost of some of these drugs costs $4,000 a month, and the co-pays on that can be anywhere from $800 to $1,000 a month for a patient, and patients shouldn't have to choose between eating and getting life-sustaining or life-saving therapy.
Okay, I'm going to have to ask you to draw it to close because you've gone over the 6 minutes, and every additional minute I'm going to have to give to the other side too.
Okay.
So
thank you.
Thank you. Let's hear any other witnesses who'd like to identify themselves and the fact of their support for the measure.
Alicia Sanchez with the American Cancer Society. We're co-sponsors, and also just like to point out that there are not intravenous options for many of these oral chemotherapy treatments. So this is the oral chemo is the only treatment for many of these patients, and would urge your support.
Thank you. Other witnesses?
Phyllis Marshall with Manat Phelps and Phillips on behalf of Carrie's Touch. I'm here to answer any technical questions. Thank you.
Thank you very much.
Thank you. Melissa Cortez Roth on behalf of Bay Bio, Northern California's Biotechnology Association. Many of our member companies produce both oral and intravenous drugs. This bill would ensure that patients have equal access to these life-saving drugs regardless of the manner that they're dispensed in.
Thank you. Any other witnesses in support? Let's hear. Is there someone else?
Yes.
Oh, right there. I'm sorry.
Line
oh,
is
right
here.
ahead. Yes. There's a line. Good.
I'm Alice Schneid, the Vice Chair of the Susan G. Komen for the Cure Collaborative's Public Policy Committee. And I am here in support. As of last week, I am a 10-year breast cancer survivor. My son is getting married this Sunday. And if I had not had access to oral and IV chemo, I would not be alive today to walk him down the aisle.
Thank you. Congratulations. Others in support?
Teresa Stark with the California Medical Association in support.
Thank you.
Reverend Tammy Denise, founder and president, breast cancer survivor, in support.
Thank you.
Margie McCutcheon, a member of Carrie's Touch. I support this bill.
Thank you.
Lynn Rankin Cochran, Vice President of Carries Touch, in support.
Thank you. Okay, so is that the end of those who wish to testify in support? Okay, why don't we ask the opposition to come down now? Maybe you can decide amongst yourselves who you'd like to have be your two principal opponents, which may be made easier by the fact that there's only two of you. Go ahead.
Thank you, Mr. Chair and members. Nick Luizos with the California Association of Health Plans. We are in opposition to the bill. First, let me start off by saying that all health plan enrollees under Knox-Keene licensed HMO plans do have coverage for oral chemotherapy. And in fact, our industry has actually praised the development of these drugs because we do see the value that they have in treatment. Nevertheless, we are strongly opposed to the bill. We are opposed because we believe that it sets a precedent for one class of drugs by forcing us to cover these drugs as they emerge online with less ability for us to negotiate those prices and to basically review them for their relative efficacy and cost effectiveness. Excuse me. In doing so, we believe this also tampers our cost-sharing mechanisms that we have in place for these expensive drugs, and in some cases, it will not be to the benefit of the enrollee. By way of background, members, there are about 38 of these oral chemotherapy drugs on the market. Only 3 of these can be substituted for infusion and IV treatment. By contrast, there are about 105 of these drugs under development currently. And it's our guess that as these drugs emerge on the market, they will be just as expensive as their existing counterparts. Our members should have the ability, therefore, as these products do emerge on the market, to take into consideration, if evidence shows that there are lower cost and more efficacious alternatives, that there be coverage for those alternatives as well. And the evidence does suggest that in certain circumstances, infusion or IV treatment is actually safer, in part because it is performed in a clinical setting. With respect to the cost, these drugs are very expensive. As noted by the author in his intro, on the eve of the Senate Appropriations Committee hearing, CalPERS was exempted from the bill as a demonstration of what the cost would be to the state. As a result, therefore, the entire cost of this bill would be borne by the private market instead. There is an extra added cost burden for employers, therefore, particularly if large group employers are obtaining their prescription drug benefits through a pharmacy benefit management company instead of the health plan, and therefore CHBRP has recognized that this will result in an increase of about $20 million overall. With respect to the cost-sharing angle of this bill, we believe the language is confusing at best and may not benefit our enrollees. If this particular drug is folded into a plan's medical benefit, which could be a result of the legislation, the enrollee could actually experience some administrative and financial hurdles up front in having this drug covered. The bill also contains language that effectively prevents a plan from adjusting its cost-sharing mechanisms with respect to this one class of drug, which affects our cost management. Finally, if the cost-sharing is what this bill is all about, there is already a process in place at the Department of Managed Health Care. Plans have to submit their cost-sharing arrangements to a regulator. If the regulator finds that those are inappropriate, they can disapprove those cost-sharing arrangements. So there is some consumer protection currently in place for those enrollees. We would add that we have not heard from any of our members that these drugs are not on our formularies or list of covered drugs. If in the future, as these 105 drugs do come on the market and the choice is made not to add a drug on a formulary, a doctor does, under current law, have the right to ask for prior authorization for coverage for a particular drug. So there is a process in place should a drug not be on a health plan formulary. So we think this bill is expensive, unnecessary, and sets a bad precedent, and we would ask for you to vote no. Thank you.
Thank you.
Jason Gappart with the Association of California Life and Health Insurance Companies. We want to echo the concerns that CAP has raised. We also want to say that, like all the mandates, we believe this could increase cost and down the road lead individuals or employers to drop coverage altogether. We also think that it sets a dangerous precedent by requiring a specific type of drug to be on a formulary at a more favorable coverage. And finally, it will also limit our members' flexibility to design their drug formularies according to the efficacy of a particular medication. For those reasons, we are opposed.
Others in opposition who just like to identify themselves?
Joe Crescione on behalf of Blue Shield of California. We're also opposed.
Dan Chick with HealthNet. We are also opposed.
Angelica Gonzalez on behalf of Anthem Blue Cross in opposition.
Senator, I do have a question, and it's raised in the analysis as well on page 7, paragraph 7B, and it goes to the language in the bill that prohibits any increase in cost sharing for cancer medications. And I guess what I'm trying to understand is in both the section of the bill dealing with the plans and the section dealing with insurance, in section B, in both of those sections, you have language that says that the plans or the insurers will review the percentage cost share for oral cancer medications and for IV or injected cancer medications and apply the lower of the two cost sharing provisions for oral cancer medications. I understand that. I'd be interested in hearing from you as to why that somewhat arbitrary approach is necessary, but I have an even bigger concern about the next sentence in that paragraph, and that just says, a health insurance policy shall not provide for an increase in insured cost sharing for cancer medications, and there's no limiting language that would limit it to oral cancer medications, for example. So I'm just trying to figure out why it's necessary to sweep so broadly in this bill to cover, I guess, any increase in cost sharing for cancer medications. And what would that apply to? Would that apply to existing contracts, new contracts, contracts going forward? So that's the and it's the question it's called out in the analysis as well.
Yes, I'm going to defer to one of the experts I brought with me.
Very good.
Mr. Chairman, the first issue you raised was with respect to the language that states that health care insurance plans shall review the percentage cost share for oral cancer medications and intravenous or injected cancer medications and shall apply the lower of the two as the cost-sharing provision for oral cancer medications. When the bill was heard in the Senate Health Committee, that issue was raised in the context of the analysis from CHPERP. CHPERP, what they stated was the language in the bill, the no less favorable language, you could actually implement that language, okay, the way it is, because it's kind of broad and vague, and it could result in actually an increase if the health insurance plan, decided to implement it, in a way where the cost-sharing provisions would create a greater out-of-pocket cost for the insured. And so in the CHPERP analysis, CHPERP made certain assumptions because the intent of the bill from the perspective of the author and the sponsors is to decrease the out-of-pocket costs at the pharmacy counter to consumers who are purchasing cancer treatment. That's the language. That's the language that CHPERP used in its assumption in the Senate analysis of this bill. And what they were intending to do was to lower the out-of-pocket cost for cancer drugs purchased at the pharmacy counter. So that language, if you look in the Senate Health Committee's analysis, it came directly out of that analysis, and it was the language that CHPERP used in its assumptions to achieve the intent of Senator Wright to lower out-of-pocket costs.
And then the next sentence in each of those sections.
Excuse me?
You've answered one of the two questions I had. The second question I had is, why is it necessary to have such broad language that basically prohibits any increase in cost sharing for cancer medications?
The purpose is not to prohibit an increase in cost sharing per se. That language was inserted in the bill to prohibit the occurrence of a health insurance service plan modifying its current allocation of cost share, whether that be a co-insurance, a deductible on the pharmacy benefit side. When you look at the no less favorable language, a health insurance plan could still comply with the bill if they decided to, in implementing the no less favorable language, they may decide to modify their cost sharing to say that now on the pharmacy side, we're going to require a co-insurance or a deductible, as is usually required on the medical side when you receive a benefit. And so that was the intent of that particular provision, is to eliminate the gamesmanship that might occur. And this was one of the issues that was prevalent when this legislation was passed in Oregon. They also used the no less favorable language, but what they saw when regs were being implemented was that you would take many of those provisions on the medical side, you would require that they be implemented on the pharmacy benefit side, and then the out-of-pocket cost for the individuals, would increase. And so that's what that language goes to. The language that CHPERP used in its assumptions may in fact eliminate that concern and eliminate the need for putting that additional language in there, but that additional language was inserted for that specific purpose, so that the no less favorable, at the end of the day, the intent of this bill is to allow for individuals like Jerry Carpenter to be able to go to the pharmacy counter and to be able to afford her chemotherapy.
Okay, I understand. It's basically what you were worried about was if the goal is to make sure that the oral cancer medications are treated no less favorably than the IV or injected ones, your worry is that what will happen is they'll raise the cost share for the other ones, and since no less favorable is the threshold, that the net result will be that everything goes up and nothing changes. But the problem, conversely, with this language is read literally. It seems to prevent the plans and the insurers from ever, in any circumstances, raising the cost sharing, because it's a sentence that stands alone by itself. It's not clearly connected up to what you've just described, and so I'm gonna see if there are other questions from the committee, and I'm going to consult with my staff, and it may be that we're going to need to work with you, assuming it's the committee's desire to let the bill out, on a different formulation here. That
Mr. Chair,
yes,
to your point, I mean that's a sentence that we have. I mean, we can work with that again. I mean, we picked it up in the Senate Health Committee, but again, if we need to make that clearer, that there's not that bright line that separates it, I think we are certainly amenable to take an amendment to make it clear that it's not that rigid. Again, the concern was that you didn't just go through a whole exercise to end up in the exact same place. So that's where we were trying to go. But if I would be amenable to taking some language. I don't have it here today, but I'd be certainly amenable to taking some language to rectify and make clear what we were talking about there. The other concern that was raised by the opposition, if I can, Mr. Chair.
Yes, sir.
The physician here particularly can talk about which drug is prescribed and the methodology for doing that, because I think one of the concerns was that we would be basically picking one treatment over another, and the physician here from UC Davis can clarify and make sure that that's not the intention, that there's a way to achieve that in a much better way. And he treats cancer patients on a daily basis, so that was the concern that I heard in the opposition. The doctor has an answer for that.
Okay. If you'd like to succinctly share that with us.
I will do my best. One additional point I'd like to make is that the Center for Medicare Services already treats oral chemotherapy drugs different from other oral medications. So there's already precedent for that at the federal level. Second, in terms of treating patients, I already have to deal with a question of whether patients can afford their medications. And we are forced daily to make decisions between intravenous and oral chemotherapy because patients simply cannot afford the copays that are forced upon them with the costs of these drugs. And oftentimes we're prescribing what we feel are less effective chemotherapy because we have no choice. We either treat the patient or we don't treat the patient, and it limits our flexibility based on simply a matter of cost.
Thank you. Mr. Fletcher.
Yeah, Mr. Chair, I just have a couple questions. If someone, is there someone from CHBRP here? I had a question about the CHBRP analysis. If someone from CHBRP could come forward, and then one of the witnesses in opposition as well. I have two separate questions. So if one of the witnesses in opposition.
So we'd like to invite up anyone here from CHBRP. Here they come.
Mr. Chair?
Absolutely.
The first, for one of the witnesses in opposition, I'm curious, with a lot of the mandate bills, we see the argument it will lead to an increase in costs, it will lead to an increase in premiums, is a pretty consistent reason to that. I did read that Oregon in 2007 put this in place, and I'm wondering what the experience has been in Oregon. Have costs and premiums gone up as a tangible direct benefit or result of this mandate?
Thank you, Assemblymember, for that question. It is true this bill has been run in a number of states this year and in previous years, and there's also a bill in Congress as a result. They are implementing the Oregon statute now. We don't have any information about the premium impacts at this point. However, I would like to bring up that one of the implementation issues that's happened in Oregon, and it's along the lines of what the chair has been asking. In interpreting what no less favorable means, some health plans have actually noticed that in implementing that language, it has not resulted in a cost decrease for enrollees. It actually, in some instances, has actually resulted in a cost increase for enrollees because the prescription drug benefit had a better cost-sharing arrangement than the IV or infusion treatment. But I'd be happy to share as the bill continues to be implemented this year to share any premium. I don't believe they have a CHBRP process there that would let us inform us.
What's the status of the Oregon bill? Because that was passed in 2007, right?
Right.
And signed into law in 2007?
Yeah.
And so has it not gone into effect?
So it has gone into effect.
It has gone into effect.
Yes.
So it has been implemented.
Right.
And there's no analysis on cost changes since then?
We have information of what the cost sharing impacts have been in terms of implementation, but I don't have any information on what the premium impacts. One of the disadvantages is that we don't have I don't believe that there's an equivalent to CHBRP in Oregon that's able to do that analysis. Sure. But I'd be happy to survey our plans that have business in Oregon and get back to you on that.
Probably won't happen before we vote on this one, huh?
No.
Just one more follow-up real quick, if I may, on that is, I mean, it's my understanding, correct me if I'm wrong here, that the CHBRP analysis gives us what they estimate it to be.
Right.
But then the actual implementation phase would tell it what it actually was. And so you're saying for Oregon we have neither of those. We didn't know beforehand what it was estimated to be, and then in 2 years of implementation we don't know if there's been any impact on premiums?
Right. I think I don't have that information, but we do have some information about how the cost sharing has rolled out, and it hasn't always been to the benefit of the enrollee.
Okay, thank you. Yeah. For CHBRP, I was curious in reading the CHBRP analysis that it said basically, if I understand this correctly, that there would be no increased utilization of oral medications, and I'm wondering how that's possible.
The estimation is that principally there would be no, not to say that it could never happen, not to say that there could not be individual cases, but at the state level for the analysis that we're presenting, we think would be very limited. California has very broad coverage already in place for oral chemotherapies. The increase in coverage is only for a few percentage points of individuals. As you know, cancer is fortunately not universal, and so the number of people receiving new coverage would be fairly low. We also saw that the literature indicates that people are quite cost insensitive when it comes to a life-saving medication, that frequently they will do what is necessary to try to get hold of the drug, which often can cause financial burdens, second mortgages on homes, needing to do other spend-down options to get them. And this also indicates that on a population basis, when we're talking at the state level, people are working very hard to have that happen. It suggests also that the change would not be so much new usage of the drugs as a shift in the costs for some of the individuals who are currently burdened.
So it wouldn't be, it wouldn't have a huge net impact on the number of people receiving the drugs because a significant portion of them are already covered, or a significant portion of those not covered find some way in order to pay. So it would just be more of a cost shift where it would make it financially easier on them, but it wouldn't reach a significant number of new people. Is that a correct assumption?
Yes.
Okay.
Coverage is already very broad.
Is already very broad.
It's already over 90%.
Okay. So it probably wouldn't. Okay. That answers my question. Thank you. And then, Senator, my final question, and then I'm done for yourself or the expert here. How does it work? My understanding of reading through the bill and kind of coming to grips with the public policy implications on this is that plans would be required to cover basically the cost of the oral medications. And my question is how that works with the formularies. And currently there's a negotiated way that that's done between the pharmaceutical industry and the insurance company. And if they're just required to cover it, is there any incentive to not have exorbitant prices for new drugs that come on the market? And would this legislation apply to any future oral cancer treatment medications that might come down the road?
I mean, it would certainly be our intention that you would look at the efficacy. I mean, because some drugs are experimental, so you wouldn't just automatically say you take that one. Right. So there'd have to be a process by which the physicians and the plan would come together and make that decision, much as the way that they do now. So if, for example, a drug was already covered in the formulary, what this would do is change the amount of benefit that you got. So it would not change that dynamic of how you worked. It would simply allow you to move.
But a new drug, so a new cancer treatment drug, would the plans would have to cover it?
It would have to first be approved and in some schematic be demonstrated that it works. So a lot of drugs are experimental, for example. So you'd still have the same dynamics. You wouldn't blanketly just say we're just taking everything that's done.
Assembly Member Fletcher, to your question, the bill requires parity between IV chemotherapy and oral. It doesn't mandate coverage. It's the no less favorable language, and so that would not be necessarily requiring a health plan to cover all chemotherapy or to put it on formulary. It basically says that there must be parity between cancer medications regardless of how they are formulated, either IV or PO. So there's not a mandate on covering chemotherapy.
Just goes back to the original question about the no less favorable. So if a new drug came on the market that was similar in its treatment to, say, an IV medication or something like that, the formulary would then be worked out in the normal, traditional way it is? Do I understand that correctly?
Yes.
Okay. Great. Thank you. That's all.
Dr. Emerson.
Senator, can you help me on the reason why you exempted out PERS on this bill?
Appropriations in the Senate. Just the threshold of when you have something, this bill would have simply died, and we looked at the $166,000 cost, and I fully intend that PERS will implement the standard once it becomes a state standard.
Oh, they haven't informed you of that. You're just assuming that.
I mean, we would pursue that, but again, I mean, the $166,000 cost in the Senate side would have meant that this bill would have been still in Senate appropriations. So it had nothing to do with whether or not I thought it was a good idea, but it had to do with whether or not, we assume that. So again, I'm fully intend that PERS, upon seeing that this is the way that we're going, will adopt it. And there's nothing in the statute that precludes PERS from adopting this as a standard.
Yeah, my problem, if it's not good enough for the state, I don't see why we're going to mandate this on the private side. But we'll see how that works out. Thank you.
Ms. Strickland.
Can I just perhaps get some clarification on the formulary and the new drugs and how that would work from the health plan perspective, please?
Right. Thank you, Assemblymember Strickland. When a health plan develops its formulary or list of covered drugs, it has a pharmacy and therapeutic committee, which consists of doctors and other clinicians that look at the evidence-based medicine and other types of research that's been done about a bill, and that, in addition to the cost effectiveness of the drug, pretty much determines whether it's going to be covered or how it's covered. We do believe that this bill is a mandate on plans. It clearly says that a health plan shall provide coverage for the drug on a basis no less favorable, but it is shall provide coverage for the drug on that basis. So we do think that in the future, as drugs come online, if a decision happens to be made that it is not a covered drug, then this would trump that, essentially. Oh, and if I do have more information on Assemblymember Fletcher's original question, if And I do apologize. Not all of our plans in California have business in Oregon, so it's kind of on a case-by-case basis. But one of our plans did experience a couple $1 million in premium increase as a result of that because of the way that the cost sharing was rearranged.
Follow up, Mr. Jones?
Sure.
Just quickly to follow up, just so I understand the formulary price. So you shall provide coverage. So if a new one comes on, you would negotiate it, but you would be negotiating with the fact that you would have to accept or provide that drug to your patients. Is that, am I understanding that correctly?
Well, I think that's unclear at best. I mean, this is a precedent. We wouldn't know how that would work. I think if the decision is that we don't cover a particular drug, then it's not on our formulary, or it could be for lack of a better word, lower down the list. We may require coverage for other types of treatment or other types of drugs before we would cover that drug. This would trump that process as well. So we think it's unclear at best. We do think that it diminishes our negotiating power, though, in crafting our formularies for these drugs.
Do you have any final thoughts on that? So I'm just trying to come to grips with how the formulary is going to work with new medication.
I think a couple of things. And I don't have the number here today for the total number of patients enrolled in Oregon. But again, if I took $2 million and spread it against the base of subscribers, I'd submit to you that we're probably not talking about a great deal of cash. And then if I measured that against the reduction in hospital stays and the ability to go to a pharmacy and go home, as opposed to having to go into a hospital, and in some instances, as you heard from a couple of the witnesses, just the difficulties that people have with the IV treatment. I would submit to you that if we measured that on a cost-benefit basis, going to a pharmacy versus going to a hospital or a clinic, I think that there's some advantage to going to the pharmacy and going home. So again, I mean, I've not seen all of it pattern out, but the other issue, Assemblyman Fletcher, is that we're also talking about in some instances whether oral medication is actually better. So what you heard from the witness was that she actually took a class of treatment that was substandard because she couldn't afford the medication. So in that instance, now you're also talking about the patient risking their life because they're having to make a financial decision. And you're right, some people might mortgage their house, they might file bankruptcy, they might do other things, but I'd submit that if I'm spreading the risk among a patient base and it's $2 million, that might be $3 or $4 per patient against the risk of people dying, as is the alternative, that I think that probably fits into where this debate's going to go. Because that is the risk that we're talking about, is that people die. And it's not a case, and as the opposition pointed out, the research and the movement in cancer drugs is now moving to the oral medications because it is a much more effective way to administer the drug. So again, as I look at it, I mean, I wouldn't try to say, oh, you can do this and there's clearly no cost. But I think you have to measure the cost of the drug versus the cost of being in the hospital. And I think that there are some countervailing benefits that make this a more practical way to go.
Does CHBRP analysis take into consideration, if you do oral medication, the less hospital-related expenses when you look at the total cost?
No, we did not look at that.
Let me just add that there are very few drugs for which there are exact substitutions for oral and IV, so it's not an easily comparable situation.
And there are 38 drugs for 52 cancers with as many as 4 stages each, and in our time frame, we couldn't analyze all the various combinations that could incur.
Mr. Gaines.
Great, thank you. I just had a question, if Nick, if you could clarify, in terms of the cost differential with orally administered versus intravenously administered medications. My concern is a cost one, because I think the bill obviously has great merit, but in terms of that cost shift that would go to the insured as a result of this type of administration of the medication, you do have an issue with patients in terms of potential copay versus a lower copay issue on prescriptions. If there was no difference in cost between something that was intravenous versus something that was orally administered, would the health plans treat it the same way?
Let me see if I understand the question.
In terms of the cost.
You mean the cost to purchase the drug, the health plan's cost to purchase the drug? Yeah, I mean, absolutely. There is a pretty huge cost differential between the different types of medication. Just looking at the medication involved, you're looking at if it's, for lack of a better word, if it's in-house and the treatment is intravenous or infusion, you're looking at for a treatment cycle, you're looking at figures in the hundreds of dollars. Excuse me, in the hundreds of dollars or a few $1,000s versus tens of thousands of dollars for treatment of the drug.
Let's say my copay on a prescription was $20.
Yes.
And yet something taken intravenously might be a much higher deductible.
Yeah.
Because you do have tiering, don't you, in terms of how
Right.
those drugs are paid for. If the two products, let's say they did the same thing,
Mm-hmm.
and you could take one orally and it was cost competitive with what you were taking intravenously,
Mm-hmm.
would the insurance companies treat that the same way as a prescription?
If the question is whether we would, if the question is whether they're the same in terms of efficacy and cost, then my understanding is that we do, like for Xeloda, for example, which is one of the very few drugs where there is an equivalent between the two. Our plans that have responded to us have said that they would cover it in that instances if it's appropriate for the circumstance.
Okay.
But there is evidence, just to respond to one of the statements that was made, there is evidence, very recent evidence by the New England Journal of Medicine that says that standard chemotherapy for certain women with breast cancer is superior to taking Xeloda. And that, in fact, women of certain ages are twice as likely to die or have a relapse of their cancer. So I think this is the type of information that we want to be able to use in crafting our drug policies.
Would orally administered medications drop in price over time?
I'm sorry?
Will the price of orally administered medications drop over time?
I think that remains to be seen. As far as we know now, there are no. We've heard of one generic alternative to an oral cancer medication, but as a category, until the generics start kicking in, we think the prices will remain to be high. They may go down over time as the marketing expenses and research expenses have been dealt with by the drug manufacturers, but it's early to tell for some of these newer drugs.
Okay, great. Thank you.
But Senator Gaines, also, as drugs are on the market over time, they go generic and the price does go down. Tamoxifen, for example, is a generic drug and the price drops substantially. Other drugs will begin to do that as well, and I think you'll also see if there is awareness that there's that competition and the drugs are being purchased, that'll also cause some of the price to go down. Part of the problem now is that so few people can often afford it that the limited sale also drives up the cost. So again, the combination of increased access and the likelihood that the drug will become generic, both of which will cause the price to go down substantially. And I think, too, to your other point, we're looking at, in California, an estimate, it might be that it's $5 a person in terms of an increased policy cost if you divide but the potential cost against the subscriber base. So, again, but we're talking about a quality of life and saving lives, which is the reason that we're here.
Mr. Amiano has a question.
Yes, well, more of a comment. I just want to compliment the senator for being bold. This should not be a bold step. This should not be microed, and I don't really see where the quibbling is coming from. I applaud you. I'm going to support this very strongly. If we don't get it out of committee, I would be happy to work with you on a bill for the future.
Thank you.
Ms. Lowenthal.
I just want to echo those sentiments, Mr. Wright. Thank you for bringing this forward. Medicine is medicine. I'd like to put me down as a co-author, if you would.
Okay. And we're going to take the amendments of the chair.
Here's where I think we are. The CHBRP analysis, which is reflected in the committee's analysis, indicates that the premium increase associated with this measure is 0.025%, and that share of premium increase associated with private employers is 0.0144%. So it's not even a single percentage point. So I don't see this as adding significant costs. And CHBRP analysis has actually said that they don't think it'll add significant costs, and it won't result in increasing the number of uninsured because it's not going to drive up the costs anywhere near a level that would cause less people to get insurance. I am concerned, though, and I do agree with the concern that was raised initially by the plans about that sentence that that you and I have talked about, Senator. And what I would like to propose is that we move your bill out of the committee, but that you work with the committee to see if we can craft a different sentence in those two sections that would capture what you're trying to capture, but would not totally constrain the ability under any circumstances to raise share of costs from now and forever for anti-cancer medications. Because I think that is an issue.
I share, and if we're too prescriptive as we are, then certainly, Mr. Chair, we would take that amendment and work with your staff to refine the language to reflect that.
Very good. Senator, would you like to close?
I would ask for an aye vote and appreciate the time you've given this bill.
Thank you very much, and we appreciate the healthy dialogue with you and your witnesses. We have a motion. We have a second. If there's no further discussion by members of the committee, the motion is due pass to appropriations with the commitment of the author to work with the committee on the language we've discussed. Let's call the roll.
Jones?
Aye.
Jones, aye. Fletcher?
No.
Fletcher, no. Adams? Amiano? Amiano, aye. Block? Carter? Carter, aye. Conway? De La Torre? De La Torre, aye. De Leon? Emerson? Emerson, no. Gaines? Gaines, no. Hall?
Aye, and that has a call.
Hall, aye. Hayashi? Hayashi, aye. Hernandez? Hernandez, aye. Lowenthal? Lowenthal, aye. Nava? Nava, aye. Perez? Salas? Salas, aye. Strickland? Strickland, no.
We got 10.
Okay, so the vote on that is 10. Congratulations, the measure's passed.
Thank you.
Thank you, Senator. You have a second measure before the committee, and that is SB 190.
Okay. Mr. Chair, members, this essentially is a bill that is a study. It, for all practical purposes, asks the Health Department to promulgate regs.
So we have a motion from Mr. Emerson. Is there a second? Second from Ms. Salas. Please, Senator, continue.
Again, I mean, it started out, it was much broader. The concern becomes is that you have a right to know, in effect, what you're buying. And a lot of people are now buying healthy things because they want to get, it's interesting, we were just talking about cancer before. Well, the antioxidant value of pomegranate juice. California happens to be one of the leading producers of pomegranate juice in the United States. A number of the imports are coming in and are not exactly, the same thing that we would have as a standard. This is attempting to make sure that California farmers and the California public and the public of the country in general, since California produces a vastly disproportionate amount of pomegranate juice, that the health department will set up standards as to what is and what is not pomegranate juice.
Very good. Do you have witnesses in support?
Yes, Mr. Chairman, George Miller on behalf of Roll International, which is the parent company of Palm Wonderful. Real simply stated, this bill is about three things. It's about consumers. It's about making sure that the consumers get what they're told they're being sold. It's about the farmers. It's about the farmers getting the price that reflects the actual world supply of pomegranates. And it's about the processors. It's about processors that are putting 100% pomegranate juice, regardless of where the source or variety of pomegranate, whether they're growing here in California, whether they're growing in Iran or Turkey or elsewhere. It's about the processors that are putting 100% pomegranate juice in the bottle, not being disadvantaged by those in the industry that try to reduce the price or extend the supply by diluting their product. With me today, I have Michael Roberts from Roll International and David Simonian, the president of Pure PJ, which is an association of farmers and processors of pomegranate juice.
Very good. Let's hear from the next witnesses.
Thank you. Michael Roberts, and it's good to be here with you. I moved to California recently and joined Roll. Prior to that, I was a international food law or food regulatory specialist, and I've also been an academic for a number of years teaching in law school. And I think I've got a pretty good handle on how this food regulatory system works. And would be happy to answer any questions relative to preemption or any other questions that this body may have. The one thing I want to say is that it's folks are always surprised at the number of ingredients that are in our food supply from different countries. And there's always consequences to that. Sometimes they're positive, sometimes they're negative. And in this particular case, we have pomegranate juice that's coming in, concentrate rather, that's coming in from other countries, mostly Iran. And that has consequences on farmers in California and consumers. That has health consequences. And this bill is one attempt that we're taking to try to repair and to stop some of these negative consequences. So we appreciate your indulgence and glad to be here.
Thank you. Any other witnesses?
My name is David Simonian. I'm president of Pure Juice Growers, and I'm in favor of this bill because I believe the import of pomegranate juice that's not 100% pomegranate juice is unfair competition to us.
Thank you. Other witnesses in support? Okay, seeing none, let's hear now from the opposition.
Mr. Chairman, members of the committee, I'm Richard Lehman with Lehman, Levi, Pappas, and Sadler, here representing the Natural Products Association West, which is an association of about 400 manufacturers and about 2,000 about 2,000 retailers of products such as this. We are strongly opposed to this legislation. First of all, I don't think it's fair, with all due respect, to characterize this simply as a study bill. It mandates the department to adopt regulations establishing definitions for this product, which would, of course, affect the eventual labeling of the product. It is our firm belief, and we believe you need to look no further than your analysis of the bill done by the staff here to come to the conclusion that this is already preempted by federal law. Federal law, and again I'll quote from the analysis, prohibits, pursuant to the FDCA, that's the Food and Drug and Cosmetic Act, any state or political subdivision of the state from establishing requirements for the labeling of food types regulated by the FDCA. Now, there's a reason for that. We can't have every state in the union deciding what orange juice is, what grape juice is, what prune juice is, just because somebody wants to say that that product is beneficial to health or whatever. You have to have a national uniform standard on this issue, and the FDA has certainly done that. And I think it would be a great disservice to the state if we spend money out of this fund, which was really designed to do much more serious things than deal with this product, like dealing with E. coli and spinach and other things. If we were to have them go through a lengthy process, and by the way, this was done once before with olive oil, which is not similarly regulated by the feds as juice products are. It took 7 years, not the 2 years in this project, and I guarantee you a lot more than $90,000 to in the end have a result that will not stand up anyway. The real entity behind this is one grower who controls about 50% of the market in this state, who we believe is attempting to label his product, and it's a very good product, Palm Wonderful, in the end, as the definitive product in this field as 100% pomegranate juice. We think that violates not just federal laws, but probably international laws as well. And unbeknownst to me, until a few minutes ago, that somebody flew out from Washington, D.C., representing the Turkish Chamber of Commerce to oppose this bill, and I hope maybe you give her a few seconds as well. This is bad policy. Let the farmers decide this, and the growers and the manufacturers work this out, rather than send this over to the Department of Health for a lengthy study that in the end is not going to generate any results anyway.
Next witness.
My name is Casey Pomerang. I'm a fifth-generation Central California farmer. My family has been farming pomegranates for over 50 years. I'm here today to represent Madera Agricultural Services and MSM Airport Group, a group of 5 families that farm pomegranates in Central California. I'm here in opposition to SB 190. I simply ask that we, as pomegranate growers, and we grow other commodities as well, have an even playing field in this country. If you pass SB 190, will have regulations, and the people who buy our products will have regulations specific to this state that will make it much more difficult for us to do business, not just in the wonderful variety pomegranate, but in the other pomegranates we grow. You also, through doing this study, may tie our hands. There are over 300 varieties of pomegranate currently at the USDA germplasm under study by UC Davis. One or more of those varieties may be found to have higher antioxidants or better growing benefits in Central California, where most of you know we have water issues. And we need to be able to have the flexibility to grow pomegranates as well as we can in California. This is a federal issue. It should be a federal issue. I ask you to make it a federal issue and give us an even playing field. The last thing we'd like to do is find out that a Washington apple grower can come forward and decide what apples are in Washington or what oranges are in Florida, because we set this precedent in California. Thank you very much. I ask that state of California spend its money on the things that it needs to spend its money on, and not on an issue that should be a federal issue. Thank you on behalf of Central California pomegranate growers.
Thank you. I think there's a minute remaining on the opposition.
Yes, on the opposition, sir. I actually flew in from Washington, D.C. My name is Dudan Yenolu, and I'm here on behalf of the Turkish Union of Chambers and Commodity Exchanges. We are a union of chambers. We have 365 of them within our umbrella in Turkey, and our annual trade with the U.S. is approximately $15 billion. We respectfully disagree with SB 190, as this bill impairs free trade, harms California distributors and sellers of pomegranate juice, and potentially would violate World Trade Organization treaty rules on food safety. WTO Sanitary and Phytosanitary Measures Agreement sets out the basic rules for food health and safety. It allows countries to set their own standards, but it also makes it against the WTO to impose trade barriers disguised as health measures. There are too many types of pomegranates in the world, and they differ in color and chemical composition, especially in their sugar and acid content. This bill, as it currently stands, is likely to lead to a very limited definition of pomegranate juice, blocking the California market to other pure juices originating from outside the state. This would then lead to a WTO violation within the SPS agreement, so other countries would then have a right to pursue complaints against the U.S. within the WTO. We urge you to vote against this bill, and thank you once again for leaving it to the FDA. Thank you.
Anyone else who wishes to place their opposition on the record, just identify yourself, please.
Right here. My name is Kim Dietz. Excuse me. I'm with Smucker Natural Foods. We're a juice manufacturer up in Chico, California. We manufacture under the R.W. Knudsen brand. I'm here in support of the opposition with my colleagues here, as well as Juice Processors Association, and I believe that you have their letter as well. If you have any questions, I'd be happy to ask.
Thank you. Anyone else in opposition?
Caroline Silvera on behalf of the Grocery Manufacturers Association in opposition.
Bill Gregg, representing the California League of Food Processors. We represent the vast majority of fruit and vegetable processors in California. Our main point is the funding mechanism. They're tapping the Food Safety Fund. Those are essentially earmarked industry funds for every program in that fund. So they're tapping a source of funding that there is no additional funds for regulations. Thank you.
George Kodakis, Department of Public Health, and we have an opposed position on this bill.
Anyone else in opposition? So we have some questions. Before we get to those, I just want to point out it's a pretty short bill. I think it's like a sentence or two. And as I read it, it doesn't say that you can't make pomegranate juice, whatever its content. It just says that the Department of Public Health will establish standards of identity for 100% pomegranate juice. So if I'm misreading this, somebody tell me, but I've just heard a lot of testimony that's raised a concern about folks not being able to make pomegranate juice anymore. And the way I read it is it's just whether or not you can label your pomegranate juice as 100% pomegranate juice. And it strikes me, I don't know, I've seen some advertising out of Florida about Florida orange juice and the content of that. And so I don't, just doesn't seem to the actual language in the bill doesn't seem to relate to some of the testimony I've just heard. So I'm a little confused, I guess. Maybe that's a question for the opponents.
Sir, what this study would do is two things that as a grower I have a problem with. First, it would take into account possibly the pomegranate varieties that are in production now and set a standard of identity based on those varieties. What we're looking at, as I said, there are over 300 varieties under study in Winters, California. So I find it highly doubtful that we're going to be able to do that in a year and a half for $90,000, number one. Number two, if that is not done in its completion, it doesn't bind my family from growing pomegranates, but it may bind my family to grow specific pomegranates. Further, if that study is completed and it's set into law, and there are pomegranate varieties that are excluded, that's exactly what it would do. It would say, okay, you can grow those pomegranates, but they're not pomegranates in California.
I just have to respectfully disagree. It just says establishing definitions and standards of identity, not of what you can grow, manufacture, distribute, or sell.
Well, standards.
It's identity for 100% pomegranate juice. So it's just identifying what is and what is not 100% pomegranate juice. Ms. Strickland, you have a question.
Thank you. Sir, if I may respond, or
I think we're going to go to Ms. Strickland now. She has a question.
Thank you. I have lots of agriculture in my district, so I can appreciate your concerns. It is critical to the industry, obviously, to have 100% accuracy in your labeling, so that we don't disadvantage California growers or manufacturers or juicers or retailers or everybody. But I'm concerned about this bill's ability to be effective in achieving that goal. I mean, I think it was mentioned that there is juice that's coming in that may be diluted or adulterated, that is not actually 100% pomegranate juice, and yet it's being labeled that way. Since that already is a violation of state law and of federal law, how does this bill affect that?
If I can answer that question.
Michael Roberts. Okay.
Thank you. We wish we could draft a bill that would solve all of the problems related to this import problem, but we can't do that. We're preempted from changing federal and state labeling law. What this bill does is it proposes, as Mr. Jones mentioned, Chairman Jones mentioned, a limited approach in establishing a standard, a measuring stick, if you will, for 100% pomegranate juice. And so, to your question, this bill is not a labeling law. It has nothing to do with labeling. It's something very different from that. It establishes a measuring stick or a standard of identity whereby that can then be used to identify what constitutes 100% pomegranate juice.
Okay, so this is not a labeling bill, and you're not attempting to address the mislabeling of the products that come in?
No, in fact, in federal law only preempts, California is not preempted from establishing a standard of identity because the FDA does not have a standard of identity for pomegranate juice. It has certain standards for juice. It has certain.
Well, I think that gets back to the point that the chairman raised, is that if a standard identity is established, you're bound to exclude certain types of pomegranates. And I think that was the point that
no, not at all. In fact, all pomegranates throughout the world can meet the standard as long as it's authentic. In other words, as long as it hasn't been diluted. Any pomegranate grown anywhere around the world, including in the United States or in Turkey or Iran or wherever they come from, certainly can qualify for the standard. It doesn't exclude any type of variety at all. That's not the intention. The only intention is to, quite frankly, put the cheaters out of business.
How does this bill put the cheaters out of business?
Because it provides a measuring stick whereby we can then know what constitutes 100% pomegranate juice. Without that, we have nothing to measure.
I would like
Can
to
I
ask,
seek some clarification over here, please?
Sure. Well, what would be the enforcement mechanism for this? Are we is the state then going to enforce whatever you decide, whatever somebody at the Department of Public Health or whoever, they oppose the bill, as I just heard, I guess they have more important things to do. But the issue, I hope so. The issue is if this is a labeling bill, because you could not put 100% pomegranate on something unless it was approved under whatever mechanism they come up there to decide what it is. And I don't see how that is not clearly preempted under federal law, and for good reason, as we said earlier. You can't have Arizona having a different identity standard than the one they develop in California, or Florida having a different one. The proper venue to take up this issue is in Washington at the FDA, not in this room.
So can I ask you, what is the identity standard then that you're talking about?
There is no identity standard for 100% pomegranate juice. There are certain labeling laws, which this bill has nothing to do with, that, well, for example, for 100% juice, all that's required under FDA regulations is you have a certain amount of sugar. So if I have a glass of water here and I put enough sugar in that glass of water, you have a juice product. And that's called a BRIC standard. Now, the labeling laws do preclude false and mislabeling. But this bill doesn't go there. It strictly provides a measuring stick. If you think of it in those terms, then I think it makes more sense. And we're not trying to change any kind of labeling laws, whether they exist in California or on a federal level.
It seems to me, though, that if that's your issue, that you are trying to identify what 100% pomegranate juice is, then it is indeed a labeling issue, because then you're talking about what is and what isn't 100% juice. My concern, though, is that it seems to me that whatever law is currently in place regarding the labeling of pomegranate juice is indeed already effective, since we've seen that there have been lawsuits by one pomegranate company, or pomegranate juice producing company, Palm Wonderful, suing another company because of mislabeling, and then they were successful indeed in winning that lawsuit. So it seems to me whatever is currently in place is effective for addressing.
If I might, Assemblywoman, you're correct in that there has been litigation over labeling and what have you. What this bill would seek to do, though, is establish a standard of identity so that anybody that may be importing pomegranate juice to this state, sourcing it from anywhere, or anybody who may be growing pomegranates and processing it within the state, there is a standard, there's a benchmark of what would be 100% pomegranate juice. So if you were to go out and source 500,000 gallons of pomegranate juice, and what hit the docks in Long Beach really was 60%, which was, I'm not good at math, that's why I went to law school, but let's say it was really 300,000 gallons of pomegranate juice blended with, grape juice. You would be able to say to your source, you didn't send me what you told me. I bought 500,000 gallons of concentrate, 100% pomegranate juice. That's not what I got. Now we would have a standard of identity. So what we're hoping is that the sources, once two of those ships get sent back with the concentrate because it's been adulterated and it's not what, in fact, we're not casting aspersions on the people that are bottling it, they're processing it here in the state or the country. But once a couple of those shipments get sent back and say, next time I want 500,000 gallons and you only have 300,000 gallons, tell me you only have 300,000 gallons. Don't send me 500,000 gallons of diluted product. That not only benefits the farmers, the growers in California by making the supply reflect the demand, but it also, in Turkey, in Iran, those growers, the prices they get for their commodity will also more closely reflect
I'm not disagreeing with
the supply and
your
demand.
contention on any
we're
of that.
hoping that the suppliers can...
Let me try another way, and I think the chair said it so well. This only seeks to say that if it says 100% pomegranate juice, it is. It doesn't say what color the pomegranate is. It doesn't say what type of pomegranate it is. It doesn't speak to the variety of pomegranate. If it's 100% pomegranate juice, then he's good to go. And it doesn't prevent somebody from saying this is pomegranate juice blend. And then it would say that so that you would not be confused. So I would submit to you that none of the other providers would be disadvantaged. This probably would provide, again, when the Department of Health did its study, they would specify these are the regs for being able to say 100% pomegranate juice. That's the extent of it. It doesn't. We don't attempt to presume what the Department of Health would do. We don't say, oh, you got to say this or that. The entire text of the bill, as the chair mentioned, leaves all of those decisions to them.
Mr. Chairman, I'd very respectfully like to disagree with the senator.
That's fine, but the way it works here is we take questions from the members, and then we hear from those that they're questioning. So it's not a.
This is in relation to the last question.
I appreciate that, but it's not a back and forth debate. It's really we're at the point in the hearing where we're trying to allow the members to make their decision, and if they want to ask a question to help that process, they're entitled to do so. So, Ms. Strickland, do you have any additional questions?
I do. Just to
okay,
sort of
can I
wrap
ask
up.
the audience if you could just keep it down, please, so we can hear up here? Ms. Strickland.
Thanks. I mean, it seems to me the point of this bill is that it's a study, but I don't exactly understand why it's necessary to have a study if the federal government already has a standard, and if Palm Wonderful has already sued successfully on the basis of that standard. Then really what does this come down to? I believe that there is a federal preemption issue. I believe that current law is strong enough and sufficient for writing any mislabeling issues, as this does seem to be a case. I am concerned about the different varieties of pomegranate all being classified as pomegranates. If you squeeze them and pomegranate juice comes out, that each of those pomegranates does indeed fall under whatever standard there is. I think there are an awful lot of issues to still be addressed, and I would be concerned that this is indeed one more study, and that any study that comes out would not indeed be able to be all-inclusive of all pomegranates that are grown in the state or imported from other countries. So I'm going to have to vote no. Thank you.
Okay, other questions or comments or statements from members of the committee? Okay, I don't see any. Senator Wright, would you like to close?
As you pointed out, Mr. Chair, this is a very short bill. It only seeks to define what 100% pomegranate juice. It doesn't say if it's 50%, 30%, that's your business. You want to mix it with pear grape juice, that's your business. If you call it 100% pomegranate juice, irrespective of the variety, that ought to be what you're assured of getting. I would ask for an aye vote.
Okay, thank you. So I appreciate the healthy debate on both sides. I want to clarify one thing I heard a little earlier, though. There was a statement made that the staff in the analysis declared that federal law preempts here. I think what the staff did was they recited the fact that there's a federal law on point, but our staff is not charged with making a determination about federal preemption. We've had a healthy debate about that. The opponents are arguing there is federal preemption. The proponents are saying there's not federal preemption because this isn't a labeling law and it's narrower than that. And I understand both sides have a disagreement about that, but I just want to clarify that the analysis does not render an opinion on that. It did include, as it should, the opponent's argument that there is a preemption issue here and what the basis for that argument is, but it doesn't reach a conclusion on that.
Let counsel didn't find a preemption either when they produced the bill.
Okay. So with that, I think we've had a very healthy discussion about the bill. The motion is due pass to appropriations. We have a motion and a second. And if there's no further discussion by members of the committee, let's call the roll.
Jones?
Aye.
Jones, aye. Fletcher? Adams? Amiano? Amiano, aye. Block? Carter? Carter, aye. Conway? De La Torre? De Leon? Emerson? Emerson, aye. Gaines? Gaines, no. Hall? Hayashi? Hayashi, aye. Hernandez? Aye. Hernandez, aye. Lowenthal? Aye. Lowenthal, aye. Nava? Perez? Salas? Aye. Salas, aye. Strickland? Strickland, no.
Okay, that measure has 8. It needs 2 more, and I want to thank all who traveled great distances, including some who traveled across the country, apparently, for attending the hearing today. Thank you very much. Thank you very much. Okay, now, I'm reliably informed that Mr. Harmon, some time ago, has decided to give up his spot to Mr. Onnested. I just want to double-check and make sure that that, in fact, is still the case, because probably an hour has gone by since that negotiation occurred. Senator? Senator Onnested, we want to welcome you to the Assembly Health Committee with bells on your feet and whistles and every way in which we can welcome you, and offer our congratulations for the upcoming birth of your grandchild. Senator, we're going to call item number 11, SB 761.
Thank you, Mr. Chair and members. It was a very enlightening discussion on pomegranate juice, but I'm going to go out and celebrate it with something a little stronger. Because while we were
just make sure it's 100%, Senator. Don't put any water in it.
While we were sitting here, it is a boy, and it's my first grandson.
Hey, congratulations. That's wonderful news.
With that, Mr. Chair, I'd like to move the bill.
Mr. Chair, members, SB 761 requires OSHPD to submit an annual report to the legislature on projects done by the Health Workforce Pilot Project. Right now, only the data that comes from these projects must be made available to the public, but you have to be able to go out and search for that data. What I'm asking is that we have legislative oversight on these projects. Over 100 of so many have been submitted. 78 projects to date have been completed, and I would suggest that the legislature is not really aware of any of these projects, either in their formulation or while they were going on, or in their completion and what they were all about. I think that it is the duty of the legislature, especially when there are taxpayer funds involved. I'm not talking about any specific project, but I'm talking about the overview of where we're asking that when taxpayer dollars are involved, for example, OSHPD spends considerable amounts of money in taxpayer money in having to evaluate whether a project qualifies and then evaluate the projects as they go through and have all of the data compiled. My office was made aware of one such project this winter and spent countless hours trying to get the information from OSHPD on this one project. And notwithstanding what that project was, data that we have asked for in February is still not in my office, especially the financial data regarding that project. I just think that as a matter of course, the legislature should have ultimate control and ultimate oversight when it authorizes special pilot projects to be done, and that we should get an annual report. That's basically all that I'm asking for in this bill. There's no cost involved in asking for this annual report, and I will also tell you that what has stimulated this is that in the one project that I did investigate, I found letters from two of the evaluators, which were OBGYN docs, who had concerns about serious patient safety issues due to lack of evaluation and data on oversight of what this project was. This bill in no way affects the project that is going on, but it will affect future projects which are being contemplated, in that all we're asking for is that once a year the director of OSHPD send an annual report to the legislature regarding what has happened in that ensuing year and how has the cost or the finances of that project, how have they been spent, and make that determination so that the legislature is aware. Now, I know that the Republican analysis, when they wrote up the opposition side, say, who needs another study to sit on a shelf somewhere and be part of the dustbin that we never read? Well, I do, because I can tell you that my office has spent an awful lot of time, an awful lot of hours in the last 6 months trying to get the data just on one research project, which if this bill had been passed, we would have simply had to go to the website and find it. And so with that, I would ask for your aye vote, and we'll leave it at that.
Do you have any witnesses, Senator?
No witnesses, no opposition. This got out of the Senate 39-0, and even the director of the ongoing pilot project today at UCSF is neutral on this bill.
Okay. Let me just make sure there's no one in the audience who wishes to testify in support of the bill. Is there anyone in the audience who wishes to testify against the bill? Questions from members of the committee? There was a question raised in the analysis, which is, in light of the fiscal crisis faced by the state, does it really make sense to direct OSHPD to undertake a study of this sort, particularly in the wake of the governor's decision to add yet another furlough day to our already dramatically diminished state workforce as a result of the 2 prior furlough days? So that'd be a question for you.
Okay. All I can tell you is that the amount of money that my office has spent trying to put the data together, I think, would probably supersede the director of OSHPD, who has that data at his fingertips, has the reports from all of the evaluators, and has them at his will, and his or her will. And the fact of the matter is that if any of you wants to have that information about any of these projects that are going on, I think it's more cost-effective to have a collection point at one place, and that's where the overall responsibility lies, which is with OSHPD. And so, as far as cost savings, the Department of Finance has said that this is cost neutral, and it did not go through appropriations.
Okay. Well, I appreciate what you're getting at. I'm not going to be voting in support of the bill precisely because I think this is not the right moment for us to lay additional reporting responsibilities. And I know we've got another committee of the legislature that's chaired by Mr. Latore that's looked at this issue of all these reports we asked for. And as you say, many of them sit on a shelf collecting dust. So I'm not going to support the measure, but obviously if there's a motion and a second, we'll take a vote on the measure. So the chair is looking to see if there's a motion or second on the measure. So there's a motion from Ms. Strickland and a second from Mr. Gaines. And is there any further? Well, I think we must have missed that then. So we'll list Mr. Adams and Mr. Emerson. It must have been at the part. It must have been at the part where he was talking about the 100% something or other he was going to have after the hearing. Okay, so we have a motion. We have a second. Any other questions from members of the committee? All right. Let's. Would you like to close, Senator?
I would just ask for your support. I think when a member of the legislature wants the data, it should be readily available and not have to spend the time and effort that our individual staffs have to do, especially when the legislature created the project to begin with. We should be given the information.
Very good. The motion is due pass to appropriate. Oh, Mr. De La Torre, you do have a question.
Is the report one time? Or
it's an annual.
It's annual.
Correct.
Is there a sunset?
There's not a sunset on the bill, no.
Okay. One of the things that, referring back to the committee, that we looked at when we looked at all these reports that flow through is that there is a sunset, so that it happens for a while, and then if members want to continue to receive that information, they can continue to receive it. I'm just making that suggestion because that was something that came up with ours. You get it once, you get it a couple times. If the legislature at that point wants to continue to receive that information, they can do that. Just a suggestion.
I would prefer a sunset. Not having thought about it, but I prefer those generally because it makes the legislature at least once every 5 years think about it.
Yeah, so something you might want to, if it gets out today, think about.
Very good. Any other questions, comments? Senator, thank you. Let's call the roll.
Jones?
Not voting.
Fletcher?
Aye.
Fletcher, aye. Adams? Amiano? Amiano, no. Block? Carter? Carter, aye. Conway? De La Torre? De La Torre, I. De Leon. Emerson. Emerson, I. Gaines. Gaines, I. Hall. Hayashi. Hernandez. Lowenthal. Nava. Perez. Salas. Strickland. Strickland, aye. That's 6.
The measure has 6, Senator.
Thank you very much for your
Thank you. Okay, next, number 5, SB 268, Senator Harmon. Welcome, Senator.
Thank you, Mr. Chairman. It's a pleasure to be here. I, too, am expecting my first grandson, but not for 2 months. Going to have to wait a little while. My pleasure to present to the committee today Senate Bill 268, which would assist the California Department of Alcohol and Drug Programs, ADP, and local governments in protecting residential treatment facilities. SB 268 has been crafted by state and local stakeholders who've worked collaboratively to design reasonable solutions to the problems associated with residential treatment facilities. If enacted, SB 268 would do the following. It would require the application for licensure through the Department of Alcohol and Drug Programs to include a self-certification that the facility complies with local zoning ordinances. Would make approved fire clearance valid only for the duration of the 2-year term of the license, require an applicant for license renewal to obtain a new fire clearance. Under current law, Department of Alcohol Drug Programs, when a license is being renewed, is not required to request a new fire clearance for the facility. If the facility operator chose to do so, the same outdated fire clearance form can be used over and over again by the operator. Clients in these facilities deserve to be in places that reflect current standards and requirements for life safety protections, which is exactly what SB 268 will do. SB 268 is supported by the League of California Cities and various other individual cities that I won't go into mentioning at this time. It is sponsored by a city in my district, City of Newport Beach, and I have with me to testify today in support of the bill Hugh Bauer on behalf of the City of Newport Beach.
Welcome, Mr. Bauer.
Thank you, Mr. Chair, members. Again, Hugh Bauer on behalf of the City of Newport Beach. We want to make clear, first of all, that we are supportive of the recovery facilities in our community, and in most instances, they are good neighbors. We sponsored this bill simply to address what we thought were a couple of minor issues. SB 268 is narrowly tailored to address 2 common sense issues as described by Senator Harmon. First off, with respect to the local zoning portion, as the Senator noted, this bill simply asks that a drug and alcohol recovery facility certify their following local land use law, something that they are required to do anyway. Despite claims to the contrary, this bill specifically does not require the Department of Drug and Alcohol Programs to do any verification of the accuracy of that claim. This bill only requires an acknowledgement by the facility that they are aware of local zoning requirements and that they comply. This bill seeks to avoid a situation after the fact where the city discovers an illegal facility and is forced to close them down, a situation that nobody wants. SB 268 only applies to the zoning verification to new applicants and notes that if the building into which the recovery facility seeks to operate is considered legal nonconforming use, the recovery facility shall be deemed conforming. With respect to the fire inspections aspect of the bill, since the passage of Proposition 36 in the year 2000, many fire clearances are now close to a decade or more, or a decade old. And since then, drug and alcohol recovery facilities have sprung up in communities all across the state. Some facilities have been in existence long before Proposition 36, before 2000. This bill is not about targeting any type of service for regulation. The state law, municipal codes, and ordinances all over require code enforcement and fire safety for collections where people are living together in hotels and apartments and residential hotels, structures that provide housing for large numbers of persons due to the increased possibility of fire, due to the increased possibility of life and property. Safety issues abound. This bill is designed for their benefit in mind. Some of the opponents have claimed that SB 268 will be a tool to wrongfully shut down facilities based on bogus or fictitious fire code violations. If that's the case, the claim is that local and state fire inspectors are complicit in fraud, and there are remedies for that. If we fear that fire marshals are likely to commit fraud, we've got bigger problems in this state than this bill contemplates. And with respect to the comment in the analysis that fire departments are short-staffed and won't respond quickly to requests for inspection, we have offered amendments, and we're willing to take that would require inspections to be done within 30 days. Otherwise, inspections shall be deemed approved. And with that, we urge your support. Thank you.
I don't know that we have those amendments.
There are amendments we've discussed with the consultant, and we can...
Do you have them in writing in some form for us?
I have them. I don't have them on me, but I can provide them to the consultant.
Okay, so you're offering on behalf of the author that we would take an amendment in this committee on the bill?
Matters to the committee.
Okay, let's hear from the next witness.
Good afternoon, Bill Higgins from the League of California Cities. And we support the bill like we support most fire protection bills. In the past we've had, and I don't think it came before this committee, but it came before the legislature, where senior residential care facilities had to file an emergency plan with our local fire departments just to assure some safety issues. I think that also we have different regulations for fire related to mobile home parks and things like that. We care about having our public safety and fire codes in line up front, and it's kind of a penny saved is a dollar earned in terms of what it costs our fire departments. So for that reason, we're in support of the bill.
Thank you.
Ann Blue with Emmanuels Jones, representing the Marin County Council of Mayors and Council Members. We're in support. I realize we're limited to 2 speakers on the bill, but we're in strong support. Thank you.
Okay, and then I think we have others who wish to testify in support. If you could use the mic at the side of the room. Any others in support? Or maybe not. All right, let's hear from any of those that have concerns or opposition about the bill. So now, maybe what we could do on the opposition is just have a couple come to the table, but others use the mic. That might be more convenient for everyone.
Mr. Chair and members, Steve Carlson for Elements Behavioral Health. In opposition, I'm here to introduce Dr. David Sachs, CEO of Elements Behavioral Health, and Mike Harold of the Western Center on Law and Poverty as our 2 primary opposition witnesses.
Mr. Chairman and members of the Assembly Health Committee, my name is Dr. David Sack. I'm a licensed physician and a board-certified psychiatrist and addiction psychiatrist. I have more than 20 years of experience in treating patients with alcohol and drug problems and mental disorder, and published over 60 articles, and been principal investigator on more than 100 research trials. I'm CEO of Elements Behavioral Health, a for-profit corporation that owns and operates alcohol and drug licensed alcohol and drug treatment programs in Southern California. Prior to joining Elements Behavioral Health, I worked for many years as president of college health clinics and Aspen Community Programs, working with the counties of Kern, Los Angeles, and San Diego counties to provide mental health and alcohol drug treatment services to the county mental health authorities. Before getting to the specifics of this bill, I wanted to reiterate that residential drug and alcohol treatment is necessary and indispensable part of treating alcohol and drug problems. Today, only 1 out of 10 clients with an alcohol or drug problem receives treatment. It is unlikely that if current education, funding, and parity initiatives are successful, that the number of licensed programs available today could meet the needs of the population that needs to be served. Studies have consistently shown that outcomes are worse when residential treatment is not an option in the service of these individuals. The populations served by our residential treatment facilities reflect the communities in which they're located. They provide treatment to your friends, children, your neighbors, and their families. And despite all of the information that has been put forward in the press, alcohol was and is the dominant problem of drug abuse in the United States today. We are strongly opposed to Senate Bill 268. The bill is both unnecessary and will have a devastating impact on licensed residential treatment homes. Cutbacks in government funding, along with the loss of insurance as a result of the current recession, has already compromised the ability of many of the providers to provide services in this area. The bill would impose additional financial burdens on a strained system. SB 268 is unnecessary. There's no documented history of fires in alcohol and drug programs, and no evidence that they are either more safe or less safe than family homes in the same neighborhoods. Alcohol drug programs, which is charged with the safety and health of residents, performs additional inspections as part of the relicensing and renewal process. There's a demonstrated history of safety and license programs that shows that the current system is working. Okay. The two main parts of the bill that we object to, first of all, Section A requires an applicant to license and to certify that the property complies with local zoning and is a legal nonconforming use. As the analysis has already pointed out, the excessive vagueness of the provision has to do with the fact that zoning laws are constantly changing. This shifts the burden from local jurisdictions to the providers to make a certification statement that they don't understand and later risk being charged with perjury. But Section B is even more troubling. It requires that facilities comply with fire clearances to a code standard that did not exist at the time that the buildings that they occupy were built. It would require extensive and expensive upgrades to facilities and would force many out of operation. It would also require retrofitting in the absence of any demonstrable safety hazard. It would make all but the newest of structures effectively unavailable for the use in treatment programs due to the unreasonable costs of retrofits. We have, along with other providers of AOD services, strong and abiding commitments to the safety of our clients and to our communities. Rampant drug and alcohol problems exact a terrible toll on the communities we serve, and effective treatment is needed to counteract this epidemic. It's our sincere desire to maintain cooperative and collaborative relationships with our neighborhoods and to preserve their character. This bill does nothing to advance that dialogue. Thank you.
That leaves about a minute for the rest of the opposition.
Thank you, Chairman Jones. Mike Carroll with the Western Center on Law and Poverty. We are in opposition to this bill, largely because there's a reason why we have state law that protects drug and alcohol facilities, foster care group homes, other kind of activities that the state promotes to try to make sure that people are in a safe environment as they recover or they work through the issues and struggles of their lives. If we allow local governments to be able to get their hands into the issue of who gets to be located into their areas, we will slowly but surely see a decline in the availability of such facilities. When we have a decline in the availability of facilities, we won't be able to help people. We won't be able to get them through drug and alcohol, substance abuse programs, and put them back on the path to being citizens who are contributing to our state. We strongly oppose this bill. We think this is merely a measure to open the door to local meddling. We strongly oppose.
Hello, my name is Tina Chigensky, and I'm representing the Department of Alcohol and Drug Programs. Our department is responsible for licensing and certifying alcohol and drug treatment programs, and as part of that, we do look to see if there's a fire clearance, if it's updated and timely. So in the application, they submit that certification that they have when it's in effect, and then when we do our site visit, we do a site visit every 2 years. And if you have any questions about what we do, I'd be happy to answer them. Thank you. We request your no vote.
Okay, other witnesses in opposition, if you just use the mic along the wall, identify yourselves and state your opposition, please.
Mr. Chairman, David Peters on behalf of the California Association of Addiction Recovery Resources. This bill is not about protecting our clients. This bill is about making us close. Thank you.
Good afternoon. My name is Stephen Mulhart. I'm
officer and director of the California Association of Alcohol and Drug Program Executives. We represent about 300 treatment providers here in California, and we oppose strongly. We believe this is a NIMBY bill being disguised as a life and safety measure.
Good afternoon. My name is Joseph Ostman. I'm representing California Therapeutic Communities, an association of drug treatment providers. We believe that the practical effect of this bill would be to put Alcohol and Drug Programs Department into a role that's completely duplicative and the purview of local localities, and we urge your no vote.
Chair, members of the committee, Robert Harris with the California Society of Addiction Medicine, California's addiction medicine treatment specialists. We have a real fragile and too small already treatment system, and things that put pressure to reduce the size of it endanger all of us as a society and the people that my physicians care for. Thank you.
Mr. Chairman, members of the committee, Randall Hager representing the California Psychiatric Association. We're in opposition to this bill for many of the reasons cited.
Craig Brown for Cliffside Malibu. We're in opposition for numerous reasons cited.
Thank you. Let's see if there's any questions from members of the committee. Well, I have a few. I guess I'm struggling with a number of things, Senator, not the least of which is I don't understand what the Department of Drug and Alcohol programs does with the information that's being provided here, because you've pointed out that, or the witnesses have pointed out that there's nothing they do with it. So I'm just trying to figure out why are we collecting it, this certification with regard to the land use.
The question is why a certification as opposed to the application process? Is that?
No, it's why would we require a certification when the department to which the certification is being made isn't authorized to do anything with that information?
Let me ask Mr. Bauer to answer that, if I could, please, Mr. Chair.
Yeah, the point is more to, as I mentioned, to kind of avoid the uncomfortable situation where the city finds out after the fact, after a facility has been opened, then the city finds out later that it's in violation of a zoning ordinance. And then this way, when the city goes and knocks on the door and says, we're going to have to close you down, you have to move, they say, well, we didn't know what the local ordinance was. This way, they acknowledge publicly, we know what it was, assuming that they checked with the city first, it's on record. If they claim they didn't know what it was, you can ask for look at the application with the department. And it's just, we thought this was a minor aspect of the bill, just to have the facility acknowledge, we know what the local zoning ordinance is, and we're appropriately cited.
Okay, but I'm looking at the DADP application, and in line 3, paragraph 3, sub A, under the heading applicant responsibilities, it says, we understand that there is an obligation to meet other state, federal, and or local codes and regulations, such as zoning, building, sanitation, labor, and non-discrimination, and some other codes. So there's an express notification to the applicants along the lines of what you've just described as your goal of the bill. There's an express notification to applicants that they do have to comply with zoning, and they're essentially certifying that they understand that they have to meet that obligation in the existing application. So I don't know why we've got to add this additional layer of certification. That's what I'm confused about.
Well, we're more than willing to work with the department to make that more clear. I was just sent the application this morning, and I haven't seen that. The department had not communicated with us prior to yesterday. So, again, I spoke to the staff yesterday and said we're more than willing to talk about that. Again, the more substantive part of the bill was the fire inspection, but...
Okay, so then on that piece, is there any evidence that these facilities suffer from a higher incidence of fires?
Not necessarily, no more so than any of the hotels around downtown, but I don't think the city of Sacramento would pass on doing regular fire inspections. It's just consistent with what the city's interest is in providing public safety in buildings where a large number of people occupy.
Okay, but in order to get a local permit to open one of these facilities, they have to meet existing codes, right?
At the time of their initial licensure, which they're required to do under existing law. What existing law doesn't provide is that or biannual every 2 years when you submit the renewal to get an updated local fire inspection.
But what the department just testified to is that they do inspections every 2 years and they look at all these things. Is that right?
Yes, it is. And we look at the date on the certification, and that's determined by local ordinances, how long a fire certificate will be valid. So we looked at the validity date. And then there are several other things we look at the facility for health and safety.
Okay. So I guess that I appreciate your intent here, Senator, but I'm just not convinced that we need to do this. And conversely, what I am worried about is what the opponents have described is a concern that this sort of set of requirements may be used as impediments to bona fide legitimate providers of these services to establishing themselves. And I know from my own experience in local government that these facilities are not highly thought of at the local level, and oftentimes, regretfully, local governments look for ways to stop them. So that's, I think, what we're trying to balance here at the state level is, and I guess the other concern I have is, I mean, we typically hear from the league and the counties about trying to make sure that local zoning and land use issues are left to the locals and the state deals with regulatory issues. This seems to me like we'd be injecting a State Department into potentially decisions about local zoning. So I'm struck by that inconsistency also.
Well, my response to that is two. One, existing law does require the local fire marshal to do an inspection in the first year of the application anyway. Our folks are telling us that the law is not clear that the local fire marshal may go in following that. So we would argue the bill is just clarifying that point. And if you know, the folks are saying that's what existing law is anyway, why can't we just sort of clarify that with this bill? That's not the advice or the understanding from our community nor the fire marshals we'd spoken to.
Okay, thank you. You want to add anything?
No.
No, okay. Any other questions from members of the committee? All right, do we have we should see if we have a motion first, and then we'll give the senator a chance to respond or close. Do we have a motion? It's a motion from Ms. Strickland, a second from Mr. Gaines. Senator, would you like to respond?
Yes, I would, Mr. Chairman. Thank you very much, and committee members, thank you for considering this bill. The bill's very simple, really. It does two things. It requires the applicant to certify that they are in compliance with the local zoning rules. And secondly, it requires a fire inspection. And the fire inspection, as between the two parts of the bill, is probably the most important. Otherwise, the operator of the facility could use the same fire inspection over and over and over again. Every 2 years when they come up for renewal, they could simply use the existing fire inspection from many years earlier. And I think it's important for public safety and safety of the occupants of these types of facilities to know that life-saving facilities that are present to prevent them from fire danger. So for those reasons, I would respectfully ask your aye vote.
Thank you, Senator. Let's call the roll.
Jones?
No.
Jones, no. Fletcher? Aye. Fletcher, aye. Adams? Amiano? No. Amiano, no. Block? Carter? Conway? De La Torre? De Leon? Emerson? Gaines? No. Gaines, no. Hall? Hayashi? Hernandez? Hernandez, no. Lowenthal? Nava? Nava, no. Perez? Salas? No. Salas, no. Strickland? Strickland, aye.
Senator, that measure is 2. It's on call.
Thank you very much.
Thank you, Senator. Thanks for your patience. Senator Duchesne, item 6, SB 289.
Thank you
Welcome,
very
Senator.
much, Mr. Chairman and members. I'll try to be briefer than the last few were. This bill would, a couple of years ago we required hospitals who were seismically vulnerable under SPC 1 buildings to report to the state on the status of compliance by June 30th of this year. Subsequent legislation that I carried last year had the 306 eligibility. We now have the HAZUS in place, and as we've been following this seismic saga, as it were, for the last 15 to 20 years for hospitals, we now are in a position where we're going to have, I think, some real information soon. What this bill does, as currently drafted, will add the reporting requirement so that we can all assess the effect of compliance, who's complying, what stage is everybody at. We have moved all these timelines so differently. This has been around the block a bit. We're getting on to 2030 now, and we're still waiting for 2008 compliance. That's 2013, 2015, 2017. We've moved the dates around a lot. Our bill last year moved it for some to 2020 with 2030 compliance, and getting our arms around the entire question is what the original intent of this bill was. As we have moved along, in the interest of full disclosure, we need to indicate that, in fact, there has been a lot of talk now, and one of the things I think we missed in the whole 306 discussion last year, we certainly weren't anticipating the credit crunch and economic decline that we have seen since then. We know that many hospitals are, in fact, not able now, for credit reasons, to comply with plans that they thought they were going to be able to comply with last year. We know that there could be a larger discussion, and the hospitals and some of the other concerned parties have been interested in having that larger conversation about how we deal with these folks who now committed to do something and now can't get the credit to follow through on their plans. But we have not amended to do any of those things yet. But in the interest of full disclosure, we know this could be a vehicle for that purpose once we have all that information.
Very good. Do you have any witnesses?
Catherine Austin Scott, representing the California Hospital Association. I'll be brief. As the senator said, the seismic mandate is drawing closer. The bill currently in print will actually provide us a more complete picture of what will happen when hospitals cannot meet the seismic mandate by 2013. And we do anticipate some of that. As the senator has said, we have heard from our hospitals the credit market has been very difficult, even for those hospitals that have been pushing forward. They have very real concerns, have been voicing those, about meeting the 2013 deadline. So the bill currently in print will give us a more complete picture, again, of when a hospital, the building that closes, the types of services they provide at that time, and the type of services they provided previously, to give the community a sense of how that closure will impact the community surrounding that hospital.
Move the
we
bill.
ask for your aye vote.
Beth here.
So we have a motion from Mr. Emerson and a second from Ms. Salas. Any other witnesses in support? Any witnesses with concerns or opposition?
Mr. Chair and members, Beth Capel on behalf of the Service Employees International Union. We are not opposed to this bill in its current form, but this is an issue of vital concern to us, and we want to register our appreciation for working with Senator Duchesne on this bill and previous bills, but we want to remind the members of this committee as this discussion goes forward about what we're dealing with here. A hospital that is not seismically sound is a pre-1972 building. We are talking about buildings that are called collapse hazard buildings. That means they are at risk of collapsing in an earthquake. They would look like this after an earthquake. This is all of you where the members of my union worked, which collapsed in 1972 in the Sylmar quake. There are other hospitals that were reduced to rubble in the 1994 Northridge quake. The requirement that hospitals retrofit has been in place for 15 years now. We have repeatedly been willing to work with hospitals that were attempting to comply with the law, and a number of the extensions that Senator Duchesne referenced reflect that. We are willing to work with hospitals that continue to attempt to comply with the law, and we concur with Senator Duchesne and with the Hospital Association that the information that we are pulling together now and that the information that this bill would provide will give us a chance to know which hospitals it is that are attempting to comply with the law and which hospitals are scofflaws. And we're sorry to say that there are some hospitals, including some very wealthy institutions, with hospital buildings on fault lines that have ignored the requirements of the law. So we just wanted to remind the committee of those basics as we move forward. As I say, we are not opposed to this bill and have appreciated working with Senator Duchesne and the hospitals.
Thank you. Anyone else who wishes to testify with concerns or questions or opposition? Any questions from members of the committee? Senator, if you do amend the bill, we'll probably want to see it again in the Health Committee. We recognize it's a little bit of a work in progress, and you're waiting to get the very information that will inform
allow us to decide
final contents of the bill. But I think you have touched on several important issues, one, not the least of which is the collapse of the capital markets that some number of hospitals were relying on to do the very seismic retrofits that we have asked them to do. And so that does pose a significant challenge. And while some may be able to self-fund, that's not the case for most, if not all. And it's a significant impediment and a realistic one. So
that's a new wrinkle to the old debate.
Indeed. So with that, we've got a motion, a second. If there's no further discussion, I recommend due pass to appropriations. That's the motion. Let's call the roll.
Jones?
Aye.
Jones, aye. Fletcher?
Aye.
Fletcher, aye. Adams? Amiano? Amiano, aye. Block? Carter? Conway? Conway, aye. De La Torre? De La Torre, aye. De Leon? Emerson? Emerson, aye. Gaines? Gaines, aye. Hall? Hayashi? Hayashi, aye. Hernandez? Hernandez, aye. Lowenthal? Nava? Nava, aye. Perez? Perez, aye. Salas? Salas, aye. Strickland? Strickland, aye.
Okay, that has 13. It's out. Congratulations. The Senate Majority Leader is next, but I'm informed that he's decided to give way to Senator Negrete McLeod, which is very gracious of him and very consistent with his leadership and gracious approach to legislation. So we're not going to call the Senate Majority Leader. We're going to call Senator Negrete McLeod. And that's item 9, SB 674.
Thank you, Mr. Chair. Members, SB 674 attempts to guarantee the public safety by strengthening the regulation and oversight of fertility clinics and surgical centers, performing cosmetic procedures, and ensuring that the quality of care standards are in place at the clinics and checked by the appropriate accrediting agency. Since fertility clinics perform... Okay, now you want us to stop, okay? That's fine.
Okay. Do you have anything more, Senator?
No, they already moved the bill.
All right.
All right. After your hour on pomegranate juice,
as is oftentimes your role on in the other party. So we have a motion, a second. Do you have any witnesses in support?
I do.
Tim Madden, representing the California Society of Plastic Surgeons. We believe there are a number of strong patient safety measures included in this bill. We are in strong support and urge your aye vote. Thank you.
Linda Whitney, representing the Medical Board of California. We're in support.
Jody Hicks with the California Medical Association in support.
Any other witnesses in support? Any witnesses with opposition or concerns? Senator, there's some questions that are raised in the analysis that I share on page 9 of the analysis. If I understand the architecture of the bill correctly, you're principally relying upon accrediting organizations to be the bodies which would be assigned responsibility for regulating a variety of different outpatient settings. And what the analysis points out is that 3 of these accrediting bodies are actually out of state. It's not entirely clear to me what authority the state has to make sure the accrediting bodies are actually following through on the responsibilities given them under the bill. So I guess that's the first question, is what authority does the MBC have to hold the accrediting bodies responsible, particularly if the accrediting bodies are not even in the state of California?
And I'll let the medical board answer the question for you.
Linda Whitney, representing the Medical Board of California. We approved the accrediting agencies. We would expect them to follow the law. If we found out that they were not and were not inspecting, we would take away their approval as an accrediting agency.
And what's the likelihood of your actually doing that? I mean, that would mean that every physician accredited by that accrediting agency would lose their accreditation, and you would do that if you found one example of where a outpatient setting wasn't complying with the requirements of the accrediting agency?
No, sir. What it is the accrediting agency would be required in their process to have a method to go out and review the outpatient surgery site. That would be part of what they do as an accrediting agency. If we found out that that was not part of their process, then we would discuss that with them. We could remove their approval as an accrediting agency. The outpatient surgery settings would be approved, and then they would, when they're up for renewal, go to a different accrediting agency.
Can you, the only language I find in the bill dealing with the MBC's authority over the accrediting agencies is on page 20, line 19 in section 9, where it says that you'll evaluate their performance every 3 years. But I don't find anything in the bill that speaks to the question of your authority to, if they don't follow through on what the bill says the accrediting agency is supposed to do. I don't find anything in the bill that says that you could then pull their ability to accredit in the state of California.
I'm sorry I didn't bring them with me, but we do have regulatory authority, and we have regulations that set the process in place of what's expected. I'd be more than happy to furnish that to your staff.
Okay.
And Mr. Chair, also the existing law provides that a clinic that is not in compliance with the specified standards may receive a reprimand, put on probation, and accredited, may be denied, suspended, or revoked, and that is current law.
Right. Well, that's in the bill itself. You've picked up language that gives accrediting agencies the ability to do those things. My question is,
how do we do it?
Is if we're going to delegate, as this bill does, all of the responsibility for licensure to the accrediting agencies, how does the state of California make sure that it holds the accrediting agencies responsible? Ms. Whitney's answer is, well, we'll evaluate their performance under the bill, apparently every 3 years, and if we feel that they're not performing, we'll remove their accreditation. To me, that is probably very, very unlikely to happen, and it strikes me that there ought to be some series of steps that the MBC is authorized to take short of that, fines, penalties, some other measures to hold the accrediting agencies accountable. And by the same token, it strikes me that this list of things that the accrediting agencies can do, which is either issue a reprimand, put a setting on probation, or then revoke their certification, is either too limited or too aggressive, that there's not some middle ground. I mean, typically when we see DPH regulatory regimes, there's some role for fines or penalties short of fully revoking their ability to do what they're doing. I mean, and because that's such a nuclear option, my sense is that that will very rarely happen. So those are what the concerns are.
Again, as private entities that we are approving, they have put forward their process, what they do. We look at that in order to approve them as accrediting agencies. We then would relook at them if we got a complaint that they were not doing what they're supposed to be doing. There is no fine authority, that is correct, but we do have authority through regulatory process to keep them in compliance. We have not had an issue with them because we can remove their ability to accredit, and that is their business.
Okay, and that's my concern, is that it'd be very unlikely for the MBC to remove the accrediting capacity of an accrediting agency because there are some violations with regard to their failure to perform the responsibilities under this bill. I mean, that's such a nuclear option that it just seems to me that it would be better to have some gradation of penalties available before you get to that option, because it's unlikely that you would essentially remove from the state of California the ability to have any accreditation.
What would be your suggestions? Would they be fines? Would they be what?
Yeah, I think both. This is sort of a two-tier architecture. You've got the MBC overseeing the accrediting agencies, and then the accrediting agencies overseeing the outpatient settings. And it just seems to me in both of those layers of the architecture, there ought to be some gradation of fines and penalties and other steps that could be taken to hold either the outpatient settings responsible or the accrediting agencies responsible. And all that's available under this bill is essentially the nuclear option, which is you either take out the accrediting agency's ability to credit or you shut down the outpatient setting. And that, it just seems to me it's unlikely that those are going to be used except in extremis.
There is another option. If we are finding that the accrediting agency is having difficulty with an outpatient setting, we do have authority over the physician, and that is the physician's livelihood and license. So that is the other option if it's actually at the practice setting.
Right, but the whole purpose of this bill is that there needs to be a layer of oversight for the settings themselves. This is the bill about the settings, not the bill about the physician. So we acknowledge you have that authority and that exists, but my understanding as to why the sponsors and the author has this other stuff in this bill about the settings is that there's a need for some additional oversight of the practices of the setting. So I'm just not convinced that what's here currently gives you as the MBC or the accrediting agency sufficient flexibility in terms of the penalties that they might assess either on the outpatient settings or on the accrediting agency to get the job done. Then the other question I have is with regard to a particular outpatient setting. It's the in vitro fertilization settings.
What is that?
Let me give you the site, Senator. If you look at, I think it's page 14 of the bill, on line 29 to 31, you're including within outpatient settings facilities that offer in vitro fertilization, but you are elsewhere in the bill. Let me see if I can find it. On page 18, lines 1 through 3, at subparagraph E, providing that the MBC may adopt standards that it deems necessary for outpatient settings that offer in vitro fertilization. So you're authorizing the MBC to directly regulate that outpatient setting, which is different from the others. I guess my question is, given the very recent and notorious and public example of a physician who allegedly exceeded the guidelines for in vitro fertilization, why would we leave it to the discretion of the MBC to decide whether it's necessary or not to regulate in this area? Why don't we just direct the MBC to adopt standards for outpatient settings that offer in vitro fertilization? Just tell them to do it because...
Well, the case came to the fore because there were no guidelines. It was all voluntary.
Right. And that's a good point. And all I'm saying is this bill continues to make it voluntary in the sense that it makes it voluntary to the NBC to decide whether it's even necessary to adopt standards. It says the board may adopt standards that it deems necessary. And I'm saying you're exactly right. There's a huge problem here. It shouldn't be voluntary. We should direct the NBC to adopt standards in this area so we don't have another circumstance where an outpatient setting that's offering in vitro fertilization exceeds the guidelines with the resulting consequences that we've all read about.
Okay, we have two people who want to answer, staff and the medical board. Go ahead.
First of all, per this section of code, they would be required, in vitro fertilization facilities would be required to meet the standards of outpatient surgery settings that are already in the code or in regulation. What this provides us is to look at those to ensure that everything is there for these particular settings that are different than the standards that were created for the outpatient surgery settings, mostly to deal with cosmetic surgery. So we wanted to ensure if there were some slight differences, we still had the authority to do something specific for this group of facilities.
Fair enough. So what would be the harm of our just directing you to adopt standards for this specific facilities?
We have not had an opportunity to meet with these facilities and the interested parties relating to these facilities to determine if there are any standards that would be different.
Okay. So you could still do those things, and we would direct you to go ahead and adopt whatever standards, but I guess the concern I have is this is all still permissive. It's all still voluntary, and that was the very thing that we're trying to get at. So,
if I may, Shannon Smith Crowley, representing the American Society for Reproductive Medicine and our affiliate organization, the Society for Assisted Reproductive Technology. There are not a lot of the accreditation standards that fit exactly for the IVF clinics. We have actually for SART membership for the clinics a very extensive process. It's very similar to accreditation, and where we're thinking about going with this is that could be revamped and turned into an accreditation program, but it is not currently in an accreditation program. As Ms. Whitney said, the other standards fit better for actual outpatient surgery. There's really not much surgery. There's some minor anesthesia used during the ovary extraction or ovarian oocyte extraction process, but it's not necessarily the same. So we're looking for some different standards, and our understanding was that we would be required to abide by those standards when they are set up by the medical board.
Okay. Yeah, I guess we have a disagreement. I mean, I think that given what we know has already occurred with regard to in vitro fertilization, at least one instance, we should direct the board to adopt standards to regulate those facilities. I think it warrants regulation. We ought to be direct about that. We'll leave to you to figure out what exactly that is, because I don't think we want to figure it out up here. But I think the legislature ought to tell you, the board, adopt standards for this so that we don't have a repetition of what just transpired. This doesn't solve it. This says you may adopt them, and I don't have a guarantee then that you will adopt them. And that's no disrespect, but I'm just saying as a matter of law, there's no guarantee that you would adopt them. So those are the concerns I have.
If I may respond also.
Yes.
That particular issue that you're talking about is a physician practice issue, and accreditation is going to be looking at the clinic standards. So actually the medical board is investigating the physician, and the society is revoking his membership.
Right, but that's the same response I gave to Ms. Whitney earlier, which is I get that. There's a direct regulatory role with regard to the physician, but what Ms. Negretti-McLeod's bill is about the outpatient setting itself and setting some standards vis-a-vis those. And I'm concerned that we're not being sufficiently directive with regard to what we want to see as a legislature vis-a-vis the NBC regulating these outpatient settings.
And we are not opposed to inserting shall over may.
In the Appropriations Committee.
Yeah, and we'll take it in the Appropriations Committee.
Okay. Let me see if there are any other questions that members have on the bill. Okay. And then with regard to the concern I raised about the lack of any additional gradations of enforcement as it relates to the MBC for the accrediting agencies and the accrediting agencies themselves relating to the outpatient settings, what's the thought there, Senator?
We model requirements for DP.
Maybe you better answer that.
Yeah.
Good.
Mr. Jones, Bill Gage with the staff of the Senator. We modeled most of these requirements after those for licensing clinics under DPH. So if something as they have done there in terms of those requirements, we're trying to make them similar and comparable. So we'd hate to do something that's different that DPH has done in terms of those requirements for licensure of their clinics.
Well, I think that the difference is that typically DPH, when it's doing licensure of things, has fine and penalty authority. In this particular instance, you're right, there is no regulatory requirements as a result of the Capon case. So to say that we've modeled this on what is the existing DPH authority to regulate in this area, I think may be circular, because there isn't any existing DPH regulatory authority.
It's the standards. This bill is actually, we had a bill exactly from last year, so we were moving forward until Capon happened. But we've actually talked with the administration about trying to fix that piece of it in terms of the Capon decision. But again, we were trying to be comparable in terms of those requirements.
Okay, and I don't think it is. I mean, I'm not opposing, Senator, the architecture that your reliance on accrediting agencies, your reliance on the MBC. I mean, I've got a lot of confidence in the MBC. What I'm concerned, though, is about the lack of anything between doing nothing and going nuclear in either case. That's what worries me, because in human nature being what it is, I think there'll be few instances where the board will decide we're going to take away the accrediting authority of the accrediting agency, or few instances, frankly, where the MBC will say we're going to totally shut down your outpatient setting. So we need something in between that, it seems to me. So.
As long as we can make it comparable, I think we just want to be out of sync with what DPH would do in terms of those licensing requirements. So if there is a fine authority, which I wasn't familiar with, we'd want to incorporate that into this bill.
Okay, so
we can work with your committee.
We work with the committee on trying to find some level of enforcement in between total removal of accreditation and total removal of the ability to practice, and we'll work together on that. Okay, very good. Is there any other discussion from the committee? Senator, thank you very much. Do you want to close?
Ask for your aye vote.
All right. The motion is due pass to appropriations. Let's call the roll.
Jones?
Aye.
Jones, aye. Fletcher?
Aye.
Fletcher, aye. Adams?
I know what it is.
Adams, aye. Amiano? Amiano, aye. Block? Carter? Carter, aye. Conway? Conway, aye. De La Torre?
Aye.
De La Torre, aye. De Leon? Emerson? Emerson, aye. Gaines? Gaines, aye. Hall? Hayashi? Hayashi, aye. Hernandez? Hernandez, aye. Lowenthal? Nava? Nava, aye. Perez? Salas? Salas, aye. Strickland?
That's 13. Thank you very much, Senator.
Thank you, members.
Majority Leader Flores, item 8, SB 364. Welcome, Senator.
How are you, Mr. Chairman?
Very well, thank you.
Okay, members, first, this is Senate Bill 364. It has to do with health facilities, and we would first like to accept the committee's technical clarifying amendment on page 4, comment 8A in the analysis. I'd like to present the bill as is. And then, members, I'd like to just tell you what this seemingly simple bill does. The bill would prevent cancer research facilities from employing directors or officers that also profit from the sale of tobacco products. It's a very simple bill. It says, as a matter of public policy, our state should prevent a practice where you sit on a cancer research board and at the same time sit on a board that deals with profits from tobacco products. This is a bill supported by the California Medical Association, and the bill also, members, now concerns biopharmaceutical companies. We also believe that there's some conflicts there. If you are a person who sits on the board of a cancer research center that researches and prevents cancer, it doesn't make sense that you also sit on a board that in many cases is in conflict when you have products for the treatment of cancer. And so, members, this bill simply says that if you are sitting on the board of a pharmaceutical company and on the board of a company that buys those same pharmaceuticals, that there is a conflict. In fact, there's at least one biopharmaceutical company that has that certain standard. And this bill is very narrowly written, members, to deal with cancer research centers and pharmaceutical companies that produce cancer drugs. And we would ask for an aye vote, and we do have witnesses in support.
Thank you, Senator. Let's hear from your witnesses.
Thank you, Mr. Chairman and members. Teresa Stark with the California Medical Association. We are pleased to be in support of the bill today. We believe that the relationships that this bill addresses are clear conflicts of interest and are particularly concerning because they may not be in the best interest of patients. Certainly, comprehensive cancer centers are superb facilities. They do amazing, groundbreaking work, and we should be very proud that we have a number of them in the state. But as a unique and narrowly focused healthcare facility, their leadership has an obligation to meet the highest standards of objectivity and ethics, independence, and fair play in the work that they do. And unfortunately, even the appearance, even the perception of a conflict of interest can be damaging to those involved and should be avoided. It is unfortunate that this has to be legislated, but when public dollars and the public health are at stake, it would seem to be an imperative that we assure that the work done in these facilities is unbiased and free of external influences. So we believe that this bill protects and furthers those principles in these facilities, and we would urge your aye vote. Thank you.
Thank you. Other witnesses in support? Any witnesses in opposition? It's a motion from Mr. De La Torre, and a second from Ms. Hayashi or Ms. Salas? Ms. Salas. Okay. Ms. Strickland has a question. No, I thought I heard it coming from over here. Let's hear from the opposition.
Hi, Marty Fisher, representing the California Chamber of Commerce. We're here in opposition. The sale and use of tobacco products is still legal in California. We oppose prohibiting individuals from serving their community boards simply because of engaging in lawful, legitimate businesses. It's not good public policy to create statute to target specific individuals and ban them from serving their community. Thank you.
Thank you.
Margaret Gladstein on behalf of the California Retailers Association. We're also in opposition to the bill. We think the bill creates a crime by status, not by conduct. Under the bill, a person will be guilty of a crime if they serve on the board of a cancer center and hold an official capacity of a company that generates more than 1% of their annual revenue by tobacco sales. This is not a crime, as my colleague just mentioned. It also prohibits officers, directors, from serving on an unrelated board of a corporation that violated state or federal controlled substance law, even if that board member had no direct evidence of conflict or was involved in the violation in any way, shape, or form. And we oppose the bill for those reasons.
Thank you.
Carrie Askew Bailey with the California Grocers Association. I would associate myself with the prior two witnesses, and we oppose the bill.
Thanks.
Mr. Chairman and members, my name is Fred Noteware. I representing PhRMA, the pharmaceutical manufacturers. Our position is opposed unless amended. We had no problem with the original bill wherein there would be a prohibition of a person being on a cancer board that had any connection with tobacco. We think that's appropriate. However, the most recent amendments, as the author indicated, now includes in that prohibition a representative from a pharmaceutical company. We feel that there is no inherent incompatibility with having that kind of relationship. We believe collaboration between cancer centers and companies bringing these drugs to market is a good thing. We also believe, though, that if there is a potential for a conflict, California law, California corporate law already speaks to the relationships when one serves on a board and their fiduciary responsibility. So we would respectfully suggest that that part of the bill be deleted. Thank you.
Mr. Chair and members, Michael Hawkins. I'm here representing CHI, California Healthcare Institute, 250 biomedical companies. I will reinforce the comments that Mr. Noteware made, that we didn't oppose the bill as it was originally drafted, but we think it's highly inappropriate to include the membership on the boards of these biomedical companies. We think that's absolutely inappropriate and are opposed to the bill in that form.
Thank you very much. Anyone else with concerns or opposition?
Melissa Cortez Roth on behalf of Bay Bio, Northern California's Life Sciences Association. In Northern California, we have both Stanford and UCSF. They are both recognized cancer institutes. Many of our members work in collaboration with those institutes. This bill would prohibit that. And as a result, we do have an opposed unless amended position also.
Thank you very much. Senator, the analysis on page 4, paragraph 8B, raises a concern that some of the opponents have raised with regard to the recent inclusion of biopharmaceutical companies in the prohibitions in the bill. And I will say that I support what your bill was doing initially with regard to trying to make sure that any potential conflict of interest with a board member who serves on the board of a cancer treatment facility, any conflict that might exist between a board member serving there and a board member serving on the board of an organization that derives revenues from the sale of tobacco products, that does strike me as an inconsistency that your bill appropriately addresses. I'm having a harder time with the recent addition of the biopharmaceutical companies, and here's why, and I want to give you a chance to address this. It strikes me that there is a body of law that makes sure that board members of for-profit or non-profit cancer treatment facilities are acting consistent with their fiduciary obligation as a board member, and that were there be a decision that they were to make that would involve somehow a potential conflict of interest with their service on a biopharmaceutical board. For example, perhaps the hospital is deciding what a seller of biopharmaceutical drugs to purchase from. That board would be obligated under, that board member would be obligated under existing law to recuse himself or herself from involvement in that decision. And I think that is strikes me as really sort of qualitatively different than the main portion of your bill, which you know it's hard to imagine the existing laws of California as it relates to fiduciary obligations dealing with the situation that you appropriately are addressing in the main portion of your bill, which is the conflict between serving on a board that sells products that cause cancer and serving on a board of an organization whose mission it is to treat cancer. Because there, the fiduciary obligation requirements of existing California law won't take care of that situation. But in the biopharmaceutical context, I think they would. And that's why I have concerns about that, and wanted to see what reply you might make, but perhaps more importantly, wanted to ask if you would consider amending that portion out of the bill.
Ms. Jones, you know I have the utmost respect for you, so I would probably say that there are times when you and I are going to disagree. This is one of the few times, I think. I actually believe that a bit of the opposite, and I do understand the structure you've mentioned in practice seems to make sense. However, I think in the reality of the world of sitting on a pharmaceutical company and yet sitting on the same research side, you know, there are all sorts of issues with inside information. There's all sorts of pressures to buy the very pharmaceuticals one might purchase, in fact, you know, the research center. So I think we are digging deeper, definitely, than the bill's original push, which was a very simple nexus between smoking and cancer research centers. However, I do believe that we are reaching in this way because there are members of boards who have all sorts of these conflicts, and they're not just the smoking and the Cancer Research Center. There are all sorts of conflicts, and I think this is one more conflict, particularly at some of our cancer research centers, that we would like to very much discuss and put out into the open. So we would ask that the committee, and I understand your thought process to put the amendment into the bill, but we would respectfully resist that and ask that the bill take the one amendment that's been offered at the very beginning, and we would like to keep the pharmaceutical in. And that's just, one of those wishes from an author, and you're staring in the eyes of the chair, but at the end, I think it does make good policy from a conflict point of view, and we are doing our best to recognize that all of these conflicts that exist from all of these boards that the legislature never gets an opportunity to get shine a light on, I think is something that we're interested in, and that this bill as a vehicle provides us that type of spotlight, if you will, and I think it's an important spotlight.
Well, Senator, I really appreciate that, and I have a great deal of respect for you also. And this may be one where we do respectfully disagree with one another. But obviously your response is a reasonable one. We may just have a different view about it. I think Ms. Strickland has a question, and then we'll hear if there are other members of the committee.
Thank you. Just a couple of questions. So if I'm a board of one of these cancer research centers, what do I have to disclose and to whom about my outside activities?
Well, I think what we're saying in this bill, and the CMA can jump in any time, I think we're saying that if you are sitting on the board of a major pharmaceutical company on the board, and you indeed sit on a cancer research center board, that what we would ask you to do is to relinquish one of those positions, either or, and not simply through the recuse process, in essence, take a pass on votes as they come up. I think ingrained in your decision at all times, if you sit on either of those boards, is the fact that you just sit on one of these major pharmaceutical boards of directors. And I think even as the opposition mentioned, this really could be solved very simply by, in essence, ending relationships that give the appearance of improprietary types of actions, and I think we do that all the time here in the legislature. I mean, I think there are relationships and things that we do that we not only do we not recuse ourselves, but we absolutely relinquish, and we're devoid of those types of decisions because we make those types of choices. And I think this is one of those bills that simply ask, when we have major research cancer centers, that in essence that these folks really pick one or the other. You're either on the research cancer side or you're on the major pharmaceutical board that is pushing drugs to the research cancer center, but you shouldn't really be on both. This is kind of the point of the bill.
Well, I think the reason why we do those things is because we're talking about having government involved. This is a private entity that is not a government one, and so it is important that we recuse ourselves when we have a financial stake. But I think that is the difference here, that there isn't necessarily an inherent conflict of interest as we talk about private bodies choosing whom they want to sit on their advisory boards,
Sure.
and that it isn't the state's role to inject itself
Sure.
in dictating who can and can't sit on the board. Who does the investigating and enforcing to make sure that your bill goes into effect?
Sure, CMA, you want to answer that?
Well, if I might, on your previous point, Assemblymember Strickland, I think that the reason that this is relevant, I think, for the legislature is the public dollars that are involved. If you are a cancer research center as designated by the National Cancer Institute, you do get federal grants, federal funding in order to do the clinical trials and the evaluation on the efficacy of the medication. And also this facility takes Medi-Cal dollars. So there are public funds that are involved. So even though technically it might be a private facility, I think to that extent, I think we should be concerned. On the second point, I think it probably depends on the individual, and if they have, for instance, if they're a physician, it could certainly be something that would be looked at by the medical board. The Department of Public Health regulates healthcare facilities, and so if there is an individual who is a member of the board of directors or an administrator of the hospital, and they are violating the law, I would imagine that would be something that would be looked at by the regulators.
In your bill, who is tasked with looking at the board members for the cancer centers and identifying what other boards they sit on?
Not sure that our bill prescribes the level of checking in, if you will. I assume that the various boards that the members sit on, whether it be the medical board or others, would probably look into this, but we certainly can prescribe that.
Well, your bill creates a crime. It creates a new crime. So my question is if you're creating a brand new crime, who's in charge of finding out whether or not people have these perceived conflicts of interest and enforcing your bill?
Yeah. I'm not sure, when you say it creates a crime, I'm not sure what section you're
I'm looking at the
referring to.
Legislative Council Digest. This
I think
bill
that's-
creates a new crime.
I think that's sort of standard boilerplate legislative
Yeah.
council language, but if it's not specified in the bill, I think that's something that is civilly enforced through the local district attorney, or, you know,
Yeah, I think
that
I don't
those
see.
are
I
pretty
don't think the
standard.
bill's intent is ever to have been to.
It's more the principle
crime.
of the matter. I don't think anyone's trying to levy fines and penalties and throw anyone in jail. I
Yeah.
think we're trying to make a point.
Well, that seems to me that would be better in some sort of Senate resolution then, rather than law that says it is a crime that you sit on a board of a cancer center and also sit on a biomedical or a biopharmaceutical firm.
You're suggesting that we should make it a crime?
You made it a crime. I'm suggesting if your records are, if your intent is to make it an encouragement, then perhaps a resolution is a better place. But you do indeed make it a crime. I have Amgen in my district,
Yes.
a very reputable, well-recognized,
Right.
highly regarded firm.
Right.
Any of these cancer centers would be extraordinarily benefited from having someone of their prestige. And as Mr. Jones mentioned, they have done amazing work in cancer research and treatment and looking for cures. So to me, that seems incongruous as well. But the fact that you do create a crime, you don't have any idea who's doing the enforcing, you don't know, you can't tell me what the penalty is. It just seems to me it's not
Yeah.
fully hashed out.
I wouldn't argue that it's a crime. I think it's very standard boilerplate language that would refer any sort of problem such as this to the district attorney. It's kind of standard language. So I'm
then
not
it would
sure.
take a county DA then to
That's my
note-
guess is probably that would be the local, law enforcement folks in which the area it's located. I mean, it seems to be the bills that we do pass simply sometimes fall to those entities, and I would say that we could make that much more clear if
And
we
I think
need to.
the administrators of the hospitals or the leadership of the pharmaceutical companies, I think, would probably step in, before it even got to that point. Certainly local law enforcement has better things to do. I would think the fact that it would be in the law, that it would, it would be addressed in that way before it ever got to that
I would
point.
absolutely agree. I would think that a board, any of these cancer center boards, could take the initiative on their own to say who are the type of people we've chosen to represent us on our board, to make decisions on our behalf, and that they should themselves identify the people that are important to include or to exclude and what other factors are critical in making that decision. I don't think that decision needs to come from the state, nor do I think it needs to be made a crime. So I'm voting no. Thank you.
Okay. Kind of figured that you're going in that direction, so.
Okay, next, Mr. Adams.
Thank you very much, Mr. Chairman. Senator Flores, I'm struggling a little bit. In fact, the irony of this is I take the opposite approach that Mr. Chairman does. I think that you could probably make a more solvent argument that there may be a legitimate conflict of interest by having somebody from a pharmaceutical company serving on the board. Although, having said that, I do believe that there is sufficient law to already protect against those types of conflicts of interest, and presuming that this person does not sit on the board of directors of either company by themselves exclusively, which no one does, I don't see how there's not already a remedy at law to deal with any kind of conflict that may arise. My bigger concern is why in the world you'd pick on tobacco companies or tobacco executives or directors or members of a board and exclude them from this in light of the fact that there are, by the National Health Standards ratings, there is something over 255 known carcinogenic creating products out in the universe, things that you and I as human beings are participate in and that are manufactured and produced. If in fact your intent is to create a bright line delineation between cancer-causing agents and serving on the board of a cancer thing, why not exclude all 250 so-called products and the people who manufacture and sell those as well?
Okay. Well, first we have to start somewhere, and I think we would start with those areas that are addictive, and any of the others that you mentioned aren't necessarily addictive. Nicotine, tobacco is, so I think we should find it a requisite, prerequisite for this type of bill to start there, and I think that we should look at various items, but this is a very modest look at our cancer research centers, which has been mentioned, receive public money, and have the ability, in essence, to have some state oversight in the management of that. We just are trying to state a principle that it doesn't really make much sense to sit on, a company that receives state and federal dollars and at the same time sit on boards that sell tobacco products that ultimately cause the need for these research centers altogether. It's just
Well, just as an aside, it strikes me as ironic, too, that I don't know that there is a tobacco company that isn't receiving some sort of federal subsidy as well. as is the nature of most agriculture. But even having said that, it does still strike me as a little bit peculiar that we would pick on one particular industry to the exclusion of all the others. And the suggestion that it somehow is a greater nexus because there's an addictive quality of cigarettes does cause me to wonder if it's your belief that there is some nefarious cause going on here, that there's this nefarious board member X, who is sitting around contemplating how in the world they can be profitable on two ends by manufacturing a product that's hurtful over here and then benefiting from the research on the other side. I mean, is it your intent to assert that those types of people are out there doing that?
I think there are people sit on both boards that would leave us to think that we shouldn't even have to think of that type of judgment between making a decision, as you've just said. If you're devoid of both boards, or at least one, we wouldn't even have to get into some of the far-reaching thinking that you're mentioning. But when you do sit on both boards, I think it leads one to think of the trade-off you've just mentioned now. I would hope we wouldn't have to think of that trade-off. And so in order to end those types of thought processes of thinking of people are doing evil things between each board, I think it's probably better just to keep yourself on one board or the other.
Mr. Adams, if I might add, the wonderful thing about these cancer centers is not only do they do research into treatment, but they do research into the prevention of cancer in lifestyle and diet and all of those things to prevent cancer in the first place. So I think it's even more poignant that if there is a link between tobacco with clearly a carcinogen and a cancer-causing substance, that an entity that is doing research into how to prevent cancer in the first place, it just seems like such a dichotomy.
But it does raise an interesting question, though, because you're talking about making a determination on behalf of a board who otherwise is going to be self-governing. Doesn't the person who stands to gain the most from a poor reputation of having a perceived conflict of interest be the very board who has the authority to appoint or remove an officer for conflict?
I think it brings, I think if you mention lots of issues that, probably we're not used to discussing in public because boards do this all the time. And I'm glad this bill is here because I think it allows us the real opportunity to talk about some of these conflicts with research institutions and the very boards that some of these research institution directors sit on and are in conflict. And I think that's a good thing to have those discussions. And whether or not you agree, whether the bill should prescribe a solution to that, I would respectfully say that you have your opinion on that. But on the other side, I think it's been a healthy debate through the Senate to bring to light to the policymakers throughout the state, and this is a very good group to start from San Diego all the way up to the north, that these conflicts do exist and they really should be discussed and solved at the board level, but when they're not, these are the types of bills that transpire and we begin the debate and the discussion. And I think in many cases these are the healthy discussions that the boards themselves should be having. But they don't have until there's a bill that somehow forces them to have these types of discussions prematurely in their mind, but long overdue from our perspective in terms of the conflicts that currently exist.
Mr. Chairman, thank you for the time.
Thank you.
Thank you, Mr. Adams. Mr. Latorre.
Just to be clear, the comprehensive cancer centers that we're talking about, there's only 6 of them, right? It's UC San Francisco, USC, UCLA, City of Hope, UC San Diego, and UC Irvine. Those are the facilities we're talking about. Those are the only ones, 6, yes. So 4 of the 6 are UCs, and the other 2 are private, but obviously large institutions within the state of California. So we're not applying it to hospitals up and down the state. It's just these 6 that are, by their nature, very involved in the research, whether it's laboratory, clinical, population-based research on cancer. So I think it's a very narrow focus on these 6 facilities and their boards. And it's to me, it's a very clear call for the people who would like to serve on these boards. If you're going to serve on these boards for all the right reasons, because they're national comprehensive cancer centers, then you can't do that other stuff. Yeah. It's optional. There's no crime here. There's no you're not making people do something, or they are making a decision on their own at those 6 facilities in the state of California. And so I understand the concerns, short of putting all the Prop 68 chemicals on a list and saying that nobody who was involved in that could serve on these boards. You can't do that. So I think the author has focused on a couple of things that make a lot of sense. One, for the obvious cancer-causing effects, and two, for the inherent conflict, because they're not asking these people to be on their boards because they're really wise business people or because they have some skill set in biopharmaceutical marketing. They're on there because they put a face related to cancer research, a positive face, on their board. That's why they're being asked to serve on those boards. That's why you get served. You get asked to be on a board for two reasons: to raise money, or to bring something to the table. And in this case, what they're bringing to the table isn't themselves; it's that relationship with the cancer center. And so, I think it makes a whole lot of sense to have this for 6 hospitals in the state of California to have this restriction. And I'm obviously going to support it. I made the motion, and I urge my colleagues to join me in that.
Any other questions from members? Okay. Senator, thank you very much. As I said earlier, don't agree with you on this one, I'm afraid, as it relates to the biopharmaceutical provision. I actually think that there are benefits to cross-fertilization between cancer treatment facilities and the biopharmaceutical industry, and we've got some tremendously talented researchers and scientists who head biopharmaceutical organizations whose talent and expertise would be wonderful to have on the boards of cancer treatment facilities. And I don't think they're just fundraising. I mean, I think they bring their substantive knowledge of what's going on in both places to both boards. And if there were to be decisions where there are potential financial conflicts of interest, I do believe that the existing laws of the state of California vis-a-vis fiduciary duty and corporate responsibility would suffice. But I respect you and I respect your authorship of this measure, and I just have to say it's unfortunate on this one we disagree. So the motion is do pass as amended, because you are taking the technical amendment that's called out in the analysis, which is at page 4, policy issue 8A. That one you're taking as an author's amendment. You're declining the other one. So unless there's any further discussion, let's give the majority leader the chance to close.
Well, I think great discussion today, and I do appreciate the committee's time. I know it's been a lengthy pomegranate juice-filled discussion earlier, and so I want to be very brief and simply say, Mr. Chairman, I do respect the committee's and the chairman's position. I would hope that the members take an opportunity to allow this bill to continue on. And if it does not reach the requisite votes, Mr. Chairman, I'd ask that we be granted reconsideration held in committee as the bill as it stands, if that's possible. So I just want to make sure I state that from the very beginning.
Certainly, Senator.
And ask for an aye vote.
Absolutely, absolutely. Let's call the roll.
Jones?
With regret, no.
Jones, no. Fletcher?
No.
Fletcher, no. Adams?
No.
Adams, no. Amiano?
Aye.
Amiano, aye. Block? Carter? Aye. Carter, aye. Conway? Conway, no. De La Torre? Aye. De La Torre, aye. De Leon? Emerson? No. Emerson, no. Gaines? Hall? Hayashi? Hayashi, aye. Hernandez? Hernandez, aye. Lowenthal? Lowenthal, aye. Nava? Nava, aye. Perez? Perez, aye. Salas? Salas, aye. Strickland? Strickland, no.
3 votes.
That's 9.
That is 9, Senator. Needs
Mr.
one more.
Thank
you
Mr.
again
Chairman.
for your courtesy.
Thank you, Mr. Chairman.
Thank you. Okay, next we're going to call item number 10, SB 744, Senator Strickland's measure. And while we're waiting for, pardon? Okay, Senator, I apologize. We've got one measure on call, and we wanted to lift the call on that item with your permission. And Member Hayashi, who was absent when we took up that measure, wanted a chance to speak to that measure. And so the item that on which we're going to lift the call is item number 3, SB 196. But before we do that, the chair is going to grant Ms. Hayashi the opportunity to speak because she wasn't here during the conversation earlier. Ms. Hayashi.
Thank you, Mr. Chair and members. Thank you, Senator Strickland, for allowing us to do this. I wasn't here when Senator Corbett presented her bill, SB 196, and I want to thank her for her very generous comments, and we are working together to improve the bill. I didn't support the bill last week because the committee analysis states that it will not save the San Leandro Hospital, and so I had a lot of concerns. Since then, we've had meetings with the senator and supporter with the California Nurses Association representatives, and we all agree that we're going to work together to fix the bill, and this is a valuable work in progress, and I would like to support the bill today, and I urge my colleagues to do the same. Thank you very much.
Thanks, Ms. Hayashi. So we're going to lift the call on item number 3, SB 196. Let's call the absent members.
Block. Conway? No. Conway, no. De La Torre? De La Torre, aye. De Leon? Hayashi?
Hayashi, aye.
Hayashi, aye. Hernandez? Hernandez, aye. Lowenthal? Lowenthal, aye. Perez? Perez, aye. Salas? Block? Block, aye.
That measure is 12. Congratulations, Senator. That measure's out. Senator Strickland, thank you for your patience. I appreciate it. And now we're going to hear from you about SB 744.
Thank you, Mr. Chair. Members, I introduced...
So there's a motion from Vice Chair Fletcher and a second from... well, we could do that, or maybe Mr. Adams. Mr. Adams. Senator, I'm sorry. Go ahead.
I was told by the legendary John Burton never talk my way out of a bill, so I'd be O'Keefe to answer any questions. If it's support on both sides, I'd rather just call the vote.
I believe it is support on both sides. I think, though, that there's a technical amendment that's called for in the analysis.
I agree to take those technical amendments listed in the analysis as author's amendments. Thank you.
Okay, very good. So, Mr. Emerson has a question.
To the representative from the department. There's a huge problem here that we have federal fees, state fees, and then we have accreditation, which they charge some fees. How come we can't negotiate some type of situation with either the federal government? All this is doing is making these tests cost more money. We had this discussion the other day in B&P, but my feeling is I don't see where we have attempted to work out some agreement or arrangement with the feds on the dual fees that we're charging these labs. It just seems inappropriate to me.
In order to move forward, that is our goal. There is language in this bill to report to the legislature about our movement towards exemption from the federal program. But in order to do that, we have to move forward and ensure that we have a strong state program. That is what this bill will enable us to do.
All right, thank you.
Any other questions for the senator or the sponsors of the measure? And anyone who wishes to testify either for or against in the audience? Yes.
Very briefly, Bob Ackerman with the California Society of Pathologists. Pathologists are physicians who often direct hospital clinical laboratories, work with the department on this bill, and Senator Strickland, and I think it's a good effort to reform the program.
Anyone else? All right. We have a motion which is due pass as amended to appropriations. Senator, would you like to close?
Ask for I vote.
Very good. Let's call the roll.
Jones?
Aye.
Jones, aye. Fletcher?
Aye.
Fletcher, aye. Adams? Adams, aye. Amiano? Amiano, aye. Block? Carter? Carter, aye. Conway? Conway, aye. De La Torre? De Leon? Emerson? Gaines? Paul. Hayashi. Hayashi, aye. Hernandez. Hernandez, aye. Lowenthal. Lowenthal, aye. Nava.
For the senator for the 19th district, aye.
Nava, aye. Perez. Perez, aye. Salas. Salas, aye. Strickland. Strickland, aye.
That measure has 13. It's out.
Thank you, Mr. Chair. Members.
Thank you very much. Okay, we have a request from Chairperson Alquist to have her staff present SB 769, item 12. We're happy to do that. So why don't we call that measure, which is item number 12, SB 769. Welcome.
Thank you, Chair. Thank you, Chair and members. Senator Alquist shares the committee's concern about the California Health Alert Network. She too would like to see it expanded. Therefore, she will amend the bill to address the concerns expressed in comment 7 on page 3 of the analysis.
Move the bill as amended.
And we have shared language with the senator and her staff that would do exactly that. So you're taking that as an author's amendment?
Yes, she's prepared to do that, Chair.
Okay. So we'll take that as an author's amendment. The motion is due pass as amended. The motion was made by Mr. Emerson and seconded by anybody? Ms. Salas. And let's see if there's anyone who'd like to testify in favor of the bill.
Chairman Jones, Bruce Palmer with the Health Officers Association of California, sponsors of the bill. We're on the front lines. We've taken some real hits in our local budgets, as you know from the analysis very clearly stated. This bill will help us to ensure to get needed money that's available at federal level into our budgets to help us prepare for the fall and the potential for another H1N1 outbreak. That's why we'd very much like you to support this bill. Thank you.
Judith Riggle with the County Health Executives Association. We support the bill for all the reasons Mr. Palmer stated.
And Michael Radigan, on behalf of the Board of Supervisors of Santa Clara County, in support.
Very good. Any other witnesses in support? Anyone with opposition or concerns?
I have a question.
Mr. Fletcher.
Just a brief question. This is basically just dictating a split the state would have to allocate its share of the money on. Is that correct?
Yes, it is. It's an existing formula that the state has been using for about 5 years for similar federal funding.
And so is it just codifying an existing formula?
This applies the existing formula to this new funding. So the formula is already there.
Right.
Mr. Palmer could speak to that better than I could.
Yeah, ever since 9/11, when the Emergency Preparedness Program was created, there's a state-local collaborative agreement that's submitted to the feds, has to be approved by the feds. It's done in concurrence with the counties, and this formula split has been put into the plan. This bill just merely codifies, ensures that split occurs so the locals who do most of the work get the funding. This is only one-time funding. This is not ongoing funding, but it'll ensure that we get some additional resources to deal with the outbreak as it occurs in the fall.
Currently, the state can allocate it however it wants, right? So the state could do it on this split, or could give more to the locals or less to the locals, or
yes, yes.
So I guess I'm just trying to understand why we'd want to take the flexibility away from the state to be able to allocate it in whatever manner it sees best fit.
Senator Alquist believes that 70% is necessary for the locals to be able to deal with this.
Right.
We're taking an existing formula that has worked well for 5 years, which has been proven to be effective, and we're putting that in. The concern is that we want to make sure the people who work on the front line get enough money to at least do a reasonable job in preventing an outbreak from spreading further than it would.
Okay. So I just want to make sure I understand it correctly. But currently the state has the money, can allocate it how it wants, and this just kind of says how the state has to allocate it for this one-time money that comes in?
Yes.
Okay. Thank you.
Okay, I want to thank, through her staff, I want to thank the senator for taking the amendment. We, Vice Chair Fletcher and I and Senator Alquist and Senator Flores had occasion to chair a joint hearing of a variety of committees between both houses on the H1N1 pandemic, at which we, number one, first heard from the public health officers about the incredible crisis they're facing in terms of staffing up to address that epidemic as well as any other number of health issues. So we're delighted that the federal government, led by the Obama administration, is stepping in with funds to help provide the funding needed to keep public health officers in place. But we also heard that the California Health Alert Network is seriously undersubscribed by clinics and hospitals and others, and there's a real disconnect in terms of getting communications out to frontline providers. And so the amendment here would allow the state portion of these funds to be used to try to address that deficiency. And so I appreciate the senator's willingness to address that concern, which came out in the course of the hearing that Vice Chair Fletcher and I were attending. If there's no further questions from members of the committee, Mr. Fletcher, anything else? Let's see, we have a motion, we have a second. The motion is due pass as amended to appropriations. Let's call the roll.
Jones?
Aye.
Jones, aye. Fletcher?
Aye.
Fletcher, aye. Adams? Adams, aye. Amiano? Aye. Amiano, aye. Block? Carter? Carter, aye. Conway? Conway, aye. De La Torre? De La Torre, aye. De Leon? Emerson? Emerson, aye. Gaines? Hall? Hayashi? Hayashi, aye. Hernandez? Aye. Hernandez, aye. Lowenthal? Aye. Lowenthal, aye. Nava? Nava, aye. Perez? Perez, aye. Salas? Aye. Salas, aye. Strickland? Aye. Strickland, aye.
Okay, that has 15. That measure is out.
Thank you.
Okay, we're going to lift the calls on some. Oh, Senator Pavley's here. Wonderful. Senator Pavley, how are you today? Great. Okay, there are a number of bills that are on call, and I think my staff has a question for your staff. So, with your permission, we'll lift some calls, and then we'll go right to your bill. And so, let's. Okay. On call is item number 2, SB 190, Senator Wright's measure. Senator Wright agreed to take an amendment at the chair's request. The chair's recommending an aye vote. Let's lift the call. Call the absent members.
Fletcher?
No.
Fletcher, no. Block? Conway? Conway, aye. De La Torre? De La Torre, aye. De Leon? Hall? Nava? Nava, aye. Perez? This is 11.
Okay, that is 11. That measures out. We're now going to call item number 13, SB 797, which is Senator Pavley's measure. Senator, welcome. Yes, we're taking your bill.
We're done with pomegranates. Pomegranates now over.
Okay, Senator Pavley, I'm sorry. We're ready to go.
Assemblymember Jones, pleasure for me to be here back in this room. It's been a little while. First of all, I'd like to start out with accepting the Chair's Committee amendments, which build on the amendments that were approved last week by the Assembly Environmental Safety and Toxics Committee. They seem to be all right with the chair in that committee, as well as the Assemblymember Fuhr, who was the author of the Green Chemistry Initiative. This puts the ban, as we talked about, on BPA bottles, cups, and jars and non-liquid formula in January 2011, unless the Department of Toxic Substance Control takes action pursuant to the Green Chemistry Initiative. And then the ban on liquid formula would take place in July 2011. That's another 6-month delay unless DTSC takes action pursuant to the Green Chemistry Initiative. I think this is a very smart tactic. Because if we're serious about the Green Chemistry Initiative, let's send them a signal saying you can't delay forever. Let's turn the lobbying power of the American Chemistry Council and all their lobbyists on the administration to get DTSC's Green Chemistry Initiative up and running. In the meantime, I know that this particular toxic BPA is a real problem in a very narrow population, and that's children 3 and under, and that's why I'm carrying this bill. Those of you who don't know me, I've had a history of carrying bills that relate to children and health. A bill to take mercury out of children's vaccines. Industry, pharmaceutical companies opposed it all the way, couldn't be done. Well, you know what? Today there's mercury-free vaccines for children and pregnant women that are now available in California. Carried a bill relating to lead and jewelry. Also carried a bill relating to getting mercury out of thermostats. There was lots of opposition saying couldn't be done. The alternatives weren't there. Not enough time, not enough time. We passed the bill, gave them a few months. They're there today. Mercury-free thermostats are in the marketplace. And in both these cases, the pharmaceutical company Mercury Vaccines and Honeywell, who manufactured the mercury-free thermostats, brag about this and when they sell their products. So it was the right thing on behalf of children, and I think this is a reasonable bill and accomplishes 2 things. Health and safety of children, paramount number 1. 200 studies have been done, peer-reviewed science on this subject. Connecticut passed this same bill. They have a similar green chemistry process. They passed the same bill last month, 36-0, signed by a Republican governor. It's in law. Minnesota has passed this bill. The Minister of Health for Canada, Tony Miller, has said the science is in when it comes to children, most vulnerable population, because of their metabolism and inability to absorb BPA into their bodies, and it affects them. How does it affect them? Particularly neurological problems. I'm particularly concerned as a mother of an autistic child that we do everything we can to take any exposure to toxics out of their food sources and reduce that exposure. And who knows, sometime perhaps in all our lives we'll see a reduction in that epidemic. I wanted to also, as far as the amendments, get back to adding Senator Padilla as a co-author. I should note for the record that he is joined by Assemblymember Ma and Huffman, who was a joint author with Assemblymember Fuhr on the Green Chemistry Initiative. Also, Senator Romero is a co-author on this bill. Senator Carol Liu is a joint author. She's equally concerned. This bill is sponsored by the Environmental Working Group and the Breast Cancer Fund. It's needed to protect that next generation of babies. Each year we delay, and even though this is a delay with the caution to get DTSC up and running with their Green Chemistry Initiative, 550,000 Californians are born and are exposed, perhaps needlessly, to this toxic. I want to make very clear that this bill not only narrowly restricts the use of BPA from food and beverage containers designed for children 3 years and under, that it only applies to sippy cups, baby bottles, formula containers, cans and bottles, and baby food jars. With today's amendments, the bill gives the Department of Toxic Substances final say on this issue, which was part of the discussion here. It does not in any way affect cans for the general population. That is in the bill. It says any food sources like your SpaghettiOs or your green beans, Campbell's soups, that's for the general population. They're not impacted by this ban, and it's specific in the language. It has to be primarily just done for the children 3 and under. We know that BPA is an endocrine disruptor. It acts like a hormone, very harmful to young children. The studies are in. This reminds me of this sort of dueling science, if you will, and creating confusion, especially the last week over in this House, of the arguments over the years in dueling science when we started talking about the harmful impacts of tobacco. It took 60 years to ban lead in paint. It also was a problem regarding asbestos. This chemical is harmful to young children, and that's why so many people are now taking action on this. For example, just since last year, and many of you heard this bill last year, there's been an expert panel of the National Institute of Health concluding that current levels of exposure are a clear risk to infants and children. Our own U.S. National Toxicology Program announced in October that the adverse effects of BPA cannot be dismissed, and they are concerned about the neural and behavioral effects upon infants. And let me respond to the chemicals assertion that the FDA says BPA is safe. Last year, they reversed that, and a review board now has demanded that the FDA more carefully assess risks, particularly to young children. SB 797 mirrors the growing movement to restrict the chemical. I mentioned that Canada's banned it in baby bottles. Minnesota, Connecticut, 22 other states have this legislation pending. City of Chicago has banned it. Senator Feinstein has introduced a bill to ban it in all products for all ages. This bill's very narrowly focused on young children. 6 of the leading baby bottle manufacturers have announced that they will no longer use this products with this chemical. You can't find BPA products in Safeway, Walmart, Whole Foods. They've taken them off the shelf. The chemical manufacturer Sunoco says it will no longer sell BPA to companies that make food and water containers for children 3 and under. And they are, just for the record, a member of the American Chemistry Council. I don't believe the American Chemistry Initiative was ever passed to delay action on chemicals, but inadvertently we have done just that. It is not up and running. If it was up and running, I wouldn't be standing here before you today. So this bill, by carefully crafting the language as suggested by your chair, Dave Jones, says it is banned unless DTSC takes an action differently, banned in 2011. I've talked to people that's going to be up and running in 2010. They have time to review the science on this particular measure, and it's in their hands. Each year we delay, however, 550,000 babies are exposed needlessly. One thing I'd like to address is access to these products. 6 baby bottle companies have BPA-free products. They have it on the label. You can look online, in fact, today online, and look up that Nestle's powder formula. They advertise online very clearly to everyone that has access to a computer. There's no BPA in cans used to package the Nestle Good Start Supreme Milk and Soy, which account for more than 80% of the type of infant formula we sell. And so the alternative products are available, but I want them to be available to everyone's children, no matter where they live. So this bill will accelerate that ramping up of alternative products and make them readily available, not just in Whole Foods and not just in Babies R Us, that today has 338 BPA-free products advertised online in their campaigns or ads, but for everyone's kids. I have with me today several speakers. Dr. First will be, are you speaking first? We'll have introduction of our two speakers. We have with us today Dr. Sarah Jansen, who's a doctor and a science fellow at the Natural Resources Defense Council, and Deborah Baskin with the Black Women for Wellness. And Bill, if you would lead us off.
I'm Bill. Before we go there, I just want to make sure that the members of the committee have a copy of the amendments that the author has agreed to take. And I just want to reiterate what those amendments are, because I think they're very significant. The members of the committee will recall that we had a joint hearing earlier this year with the Environmental Toxics Committee chaired by Mr. Chesbro to make sure that everybody was up to speed on the Green Chemistry Initiative, and so that all members of this committee and frankly the legislature at large knew that we had enacted a Green Chemistry Initiative last year, and that set us on a path for the Department of Toxics to actually go through and ultimately decide what chemicals are permissible and what chemicals are not permissible in manufactured distributed goods. I will note parenthetically that this is the only chemical bill of which I'm aware to come forward to this committee, because I think there was a strong sentiment in that joint hearing that we've established this regulatory process, we should let it work. At the same time, both chairs and members acknowledge that there may be some examples of chemicals that meet a certain threshold that do require a more immediate response. The amendment that Senator Pavley has taken, I think, is very consistent with the Green Chemistry Initiative and that statute, in that it does the following. The amendment says that the department will have a substantial amount of time to decide whether it wants to regulate in this area, up to January 1st, 2011. That actually pushes back by a year the date that the ban was going to begin in Senator Pavley's bill as initially presented to this committee. If they don't act by January 1st, 2011, and this basically nudges them then to get about the business that we statutorily assigned to them last year, then the ban would go into effect, limited to the items that Senator Pavley has mentioned, on January 1st, 2011. However, the Department of Toxics can still take regulatory action after that, which could include keeping the ban or not keeping the ban, or eliminating the ban. I mean, they have that purview to do that. Could strengthen the ban, could eliminate the ban. Under the terms of the amendment, we let that regulatory body make that decision, but we're putting a marker down as to when we expect them to make that decision. That's the January 1st, 2011 date. With regard to baby formula, there was an amendment that the Senator took on the Senate side that created a separate deadline for that of July 1st, 2011. These amendments continue that particular carve-out, if you will, that particular special treatment for the baby formula of July 1st, 2011. Again, saying that the department has until July 1st, 2011 to decide what to do about baby formula. If they don't act, the ban would go into place. But after that, the department could act and either strengthen the ban, keep the ban as it is, or, in their purview, eliminate the ban. So that's I think it's a significant amendment. I think it brings the bill into greater consistency, 100% consistency with the initiative. And also I would point out that with regard to the alternatives issue, that is, how do you make sure that manufacturers of these products have time for alternatives? We're giving them an additional year in which to do that. So that's the amendment. We can hear now from the sponsor.
Bill Alio, Environmental Working Group, co-sponsor of the bill. That's an excellent summary. We've reviewed the amendments and agree with them all. I just will cede my time to the other speakers, mindful of your 6-minute limit total for the witnesses. So they're going to address further the science involved here and the need to take urgent action. And there are also people who work with women and infants and children. Thank you.
Good afternoon.
Let's hear from the next witness, please.
Good afternoon. My name is Dr. Sarah Jansen. I'm speaking here on behalf of the Natural Resources Defense Council, NRDC. I'm a physician with an appointment in the Department of Occupational and Environmental Medicine at UCSF. I also have a PhD in reproductive biology and expertise in chemicals that mimic hormones, such as the chemical bisphenol A, or BPA. As a physician, scientist, and most importantly, a mother of a young toddler, I am really concerned that current levels of exposure to this chemical are impacting human health. This has been consistently shown in animal studies, and Because of their underdeveloped detoxification systems, infants have a reduced capacity to detoxify BPA, meaning that they are exposed to higher levels of the active form of the chemical during critical periods of growth and development. There have been over 200 studies published in peer-reviewed scientific journals which have shown that exposures occurring during fetal and early childhood development are associated with reproductive harm, including the early onset of puberty, precancerous changes in the prostate and breast tissue, and neurodevelopmental harm. More recent research has demonstrated that bisphenol A can interfere with the development and function of fat tissue, leading to the development of prediabetes, cardiovascular disease, and obesity. I think all of us can agree these are all conditions which plague our population now, and increasingly exposures happening early in life have been linked to the development of chronic disease, which doesn't appear until decades later. Also of concern are studies which have recently been done in non-human primates, which have shown that exposure to BPA during critical periods of development in the brain are associated with problems in learning and memory, as well as causing male monkeys to behave more like female monkeys. In sum, we have abundant and clear evidence which has consistently shown that the developing infant is exquisitely sensitive to this chemical. I'd like to close by reading a quote from the Endocrine Society, which is a premier professional organization comprised of over 14,000 research scientists and physicians from over 100 countries. They issued their first public statement on endocrine disrupting chemicals and their impacts on human health in just the last month. They highlighted BPA as one of the chemicals which has been linked to a wide variety of health impacts caused by hormone-disrupting chemicals. The sales of BPA products, as you have already heard, have skyrocketed as more alternatives have become available. However, we cannot rely on these voluntary measures to protect our children. Further, frenzied parents shouldn't have to take advanced chemistry lessons to figure out which products are safe for their children. SB 797 carefully follows the latest research and targets babies feeding products because the science is most clear about exposure in young populations. I urge your support of this important measure. Thank you for your attention.
Next witness.
Good afternoon. My name is Dara Baskin, and I'm a mother of a 3-year-old. I'm a doula and an educator from Los Angeles. My life work and passion is to educate women and families about their options for personal and familial health and safety throughout pregnancy and postpartum. I give women the knowledge they need to have a healthy start for their families. In doing this, I recommend products and services which I deem safe, healthy, and affordable. I know and understand their concerns and needs, and no family that I've worked with would knowingly purchase products with toxic chemicals. I am here to ensure that children have the best possible start, and exposure to BPA and other toxic chemicals is not it. In learning about BPA, it began to change what products I purchase and the recommendations that I make for my clients. I want to know that my recommendations are and will be affordable, attainable, and most of all, safe. That families can go to their local store and purchase BPA-free baby products without the high overhead costs and anxiety of health risk, and without having to guess which products are BPA-free and which are not. I serve regular, everyday working families who want to know that their products are safe. And when I go to the 99-cent store, I expect, but I'm not guaranteed, that the baby products are BPA-free, versus the knockoff toxic products and formulas that could not be sold in other neighborhoods. The wealthy can choose to purchase BPA-free products online and elsewhere to ensure that their children are not exposed. But this is not an issue of choice. It's about my right to health and safety. I'm asking for equitable and affordable access, regardless of education, income, and neighborhood. Low-income families and families of color strive to be the best parents possible, but I don't believe I should need to be a scientist in order to make sure my children are safe. I'm standing up for every California mom and family to demand that baby products are safe, and our children should be protected and cared for as they are more sensitive to toxic chemicals. All women and children, regardless of income or neighborhood, should have access to safe products. And we do know that affordable alternatives are on the market. So now is the time to make sure they're in every store and on every shelf. And I urge you to support SB 797. Thank you.
Thank you very much. So I think the remaining witnesses would just identify yourselves and the fact of your support at this point. Are there any others?
Sure.
Yes. Gretchen Lee Salter on behalf of the Breast Cancer Fund. We're an organization that focuses on breast cancer prevention by looking at the environmental causes of the disease, have been very concerned about bisphenol A for a long time and its links to breast cancer causation. Very much in support of this measure and really appreciate the amendments that have been taken today since we were such a strong supporter of the green chemistry legislation last year.
Thank you.
Mr. Chair and members, Terry Calgar-Hill on behalf of the California WIC Association, along with our national partners, the National WIC Association, in strong support.
Thank you. Others? Yes.
Martelina Arguello. I'm the Executive Director of Physicians for Social Responsibility. We're a membership organization of physicians. We educate physicians, but also work extensively in communities, particularly with women, around reducing their exposure to toxic chemicals, pesticides, and BPA. We're in strong support of this bill.
Wonderful. Yes, back in the back.
Mr. Chairman, members, Justin Milan on behalf of the California League of Conservation Voters. This is one of our highest priority bills this year. We urge your aye vote.
Thank you.
Dustin Lauerman with the Planning and Conservation League. We support this bill.
Erin DePay with Planned Parenthood Affiliates of California, also in support.
Lori Chin on behalf of Clean Water Action, in support.
Nicole Wortelman on behalf of the City and County of San Francisco and Alameda County Board of Supervisors, in support.
Richard Holliber, Consumer Federation of California, in support.
I'm Dr. Sunita Hirani from UCSF. I strongly support the bill.
Latifa Apatera from the University of California, San Francisco, support the bill.
Hello, I'm Dr. Erica Schwelk, a physician with UC San Francisco. I also support the bill.
Hi, I'm Ansha Miller, Policy Director for Center for Environmental Health, also strongly support the bill.
Mr. Chair, member Stephanie Roberson on behalf of the California Nurses Association, always in support of our patients as well as children, the most vulnerable of our population, in strong support. Thank you.
Michael Endicott with Sierra Club California, in support.
Okay, let's hear now from those in opposition or have concerns.
Mr. Chairman and members, Tim Shestak with the American Chemistry Council. I'd like to divide my comments into two parts. First, to address some of the allegations made by the proponents that kind of quote-unquote the science is clear regarding the health impacts of BPA, and then make a few comments about the state's Green Chemistry Initiative. First, you heard today that the proponents indicating the science is clear on the alleged dangers of BPA. This allegation is in stark contrast with the list of international regulatory bodies that have looked at BPA as it's used in these applications and have come to a very different conclusion. To name just a few, European Food Safety Authority, French Food Safety Authority, Danish Environmental Protection Agency, Swiss Federal Office of Public Health, Japanese Ministry of the Environment, Food Standards Australia, New Zealand. Just last month, the United Kingdom Food Standards Authority stated, and I quote, "We do not believe that UK consumers are exposed to levels of BPA that would be considered a danger." And the European Food Safety Authority just last month said, and I quote, "None of the studies which have so far been published have brought into question EFSA's previous findings on BPA." You know, regardless of your opinion about the US FDA's assessment, the European Union, the Japanese, the Germans, whoever you want to take a look at, California is in a unique position to address these issues in a scientific manner. I'm just now getting a copy of these amendments, so we haven't had a chance to kind of digest exactly what they do. But the state, last year, as everyone knows, has passed the Green Chemistry Initiative, giving the authority to the Department of Toxics to identify priority chemicals, to evaluate them in consumer products, to assess alternatives, and then take action if necessary, including up to a ban. We frankly don't believe that the proposal, as I understand it, in terms of the amended bill, is consistent with the Green Chemistry Initiative. The department has authority to identify those priority chemicals. That program is up and running. We believe it should continue to be allowed to be up and running, and would encourage a no vote on this bill. Thank you.
Thank you.
Good afternoon, Mr. Chairman and members. David Topp,
with Abbott Laboratories, testifying here on behalf of the International Formula Council, which is the association that represents the formula manufacturers throughout the world. We are in opposition to this measure, and for kind of different reasons than Mr. Shestak. The formula folks, we don't make BPA, we don't make any money from BPA, and frankly, we have no stake in BPA. Our only concern is providing safe product to our consumers in the federally regulated and federally mandated containers that we have in front of us. And regardless of what has been said today, I will tell you that from Abbott's perspective, and you'll hear from other formula manufacturers later, we do not have containers that can comply with this statute. And the net effect of that is that products are going to come off the shelves. The amendments today don't change that fact. And the reason that we have to go through that circumstance is we are regulated differently than, say, someone making green beans or something like that. The federal government has a completely different statute for us. They rightly hold infant formula manufacturers to a higher standard because we are the sole source of nutrition for so many children. What they say to us when we want to make a change in our containers or a change in our formula is that we have to go through extensive testing to prove to them that the change will be as safe and as nutritious as the current product. The FDA, as you heard from Mr. Shestak, has repeatedly said that they believe that BPA at its current levels is safe. If we were to change these products, change the containers, what we would have to do is basically find an alternative, which we don't have at this point, that would meet the criteria established in this bill. Take that alternative, put new product into it, and test it over the shelf life of that period. That's up to 2 years. What we want to do is we want to collect data, and what the FDA requires us to do is to collect data to show that the integrity of the container stays intact, the nutritional value of the formula stays intact. And they want to see that because there are constant chemical reactions going on between the food in the container and the container itself. We then need to show them that data and show why the change would be okay. That process takes 2 to 3 to 4 years once you actually have an alternative. We do not have an alternative right now. And one of the samples that the Senator has in front of us is one of my products, and I will tell you that our lawyers and our regulators and our scientists tell us that we're going to pull that off the shelves. And we don't have a single container that we don't have a single mass-produced container that we think could qualify for this and that would meet the federal requirements, even with these amendments today. So for that reason, as I said, we don't make BPA. We don't make any money from BPA. Our concern is about safety for our patients and our consumers, and because of that, we have to oppose this legislation. Thank you.
Thank you very much. Anyone else in opposition?
Caroline Silvera on behalf of the Grocery Manufacturers Association in opposition.
Bill Gregg, representing the California League of Food Processors, also opposed.
Michael Hawkins on behalf of the California Healthcare Institute in opposition.
Patrick Leathers with the Gualco Group on behalf of the Can Manufacturers Institute, and we too are looking closely at the amendments. And as the previous gentleman testified, we don't have a stake in BPA. We don't manufacture it. We do emphasize making a container that is safe. We were asked by members to provide information in regards to alternatives. There are 1,500 at least different formulas for making a can safe, and we appreciate the author recognizing the complexity of alternatives or the lack thereof, and we stand ready to answer any questions if you'd like.
Thank you very much. Anyone else in opposition or with concerns?
Jessica Wolf, I'm with Boston Scientific, one of the world's largest medical device manufacturers. We are opposed unless there is a medical device carve-out, so to speak, included in this bill, as we make enteral feeding tubes to deliver nutrition to children, and I'm not sure if the sponsor intends to include our products or not, but we respectfully oppose without that.
Okay, we'll give the author a chance to answer all of those questions. Let's just make sure we've got everybody who wanted to testify about the bill who's testified, and I think that is the case. So why don't we give the author a chance to respond, and then we've got some questions from members of the committee. So do you want to respond? Okay.
I'd be glad to respond to some, and if all right, I'd like to have Gretchen pick up on anything I left out. I'll start with the grocery people first because they came up and showed up at the environmental safety and toxics. I'll repeat again, this product is not for the general population. It has to be primarily geared for, that's infants and young children, in bottles, products you'd put in bottles, cans, tippy cups, and those kinds of things. There are alternatives readily available on the market. They're certainly advertising them for BPA-free. That's online in their ads and in their products themselves on there. Regarding the dueling science, creating confusion is the way you get people to vote no on an initiative. Creating confusion is what we're trying to stir up here today. Well, here's the good news. This could be the last time you have to hear a BPA bill because we're kicking this over to DTSC. They have a year to review it. They're supposed to be up and running by the end of this year, early 2010. They have to, by January of 2011, they can decide whether the ban goes into effect. They can decide whether to amend it in some way. They can decide that the science is still not there and not go forward with the ban. In the meantime, they have 2 years to ramp up their products. How do we know they will do that? The public is demanding it. We are seeing, just compared to last year to this year, an extraordinary number of products, 388 online advertises BPA-free and Babies R Us just today. There are alternatives. I would like to correct one comment. I believe it was from the representative from Abbott. The FDA has no required timeline. They keep talking about timelines and 2 years of short shelf life and other things. There is no required timeline. A lot of this misinformation out there is to create this confusion, and the idea here is BPA, there's enough red flags here. Other states have banned it, Canada. Japan has banned use of cans. I know these companies are capable of providing safe formula and bottles and sippy cups for our youngest children. We've given them enough time through this process, and we have an extra layer of scientific review through the green chemistry process. Let's work together, including the opposition, to tell the administration, high priority for everyone. Let's not hear these in front of this committee anymore. Let's move the process down the road. This will make sure it's a priority for them to have this process up and running. Otherwise, delay for the sake of delay maybe is to their benefit in some regards, but it's not to the benefit of the 550,000 children that are born each year. So I support your compromise. I think it's reasonable. I think it takes away the dueling science kind of component that we heard today. And perhaps Gretchen has something else to say in response to the opponents.
Well, can I just, actually, in the interest of time, maybe what we ought to do is just go right to the questions from the members, and then you'll have an opportunity if there's additional questions. So we've got Ms. Strickland and then Mr. Emerson. And Ms. Saliston after that.
Is DTSC here? Is any representative from DTSC?
Not that I know of.
Have they given you any indication how long it would take them to look at BPA and evaluate whether or not they should?
Well, maybe someone else can answer it, but I've talked to Assemblymember Fuhr, who's very interested in this subject, as well as Assemblymember Hoffman. They're supposed to have the regs and everything in place, the protocols, by August and up and running by the end of this year or at the latest beginning of next year. So I know it's a high priority with the administration. So this, I think, will provide that impetus, if you will, for the people concerned about health, as well as the young mothers and children that are now being born today, as well as the American Chemistry Council, to say everyone wants this process up and running in 2010, which would give them ample time to review all this by the time they go into place. 2010 and 2011 in January, the formula in July of 2011.
Well, I don't have a problem holding the department's feet to the fire regarding any of these issues. I've asked things of different departments and agencies, and if it's not a priority, it doesn't get done. So I appreciate the amendments that you've taken to the bill, and that, I supported the Green Chemistry Initiative last year because I do believe there has to be a deliberative, scientific way to look at all of these different chemicals that are being used in children's products, for example. I did have a question. Is it possible for a product that has no BPA is not added, or it's not used in the making of a product, for it to actually test positive for BPA at the levels established in your bill?
I'm going to have Gretchen answer, because we just heard that was being asserted out there, that somehow it's an airborne contaminant that could leach into the product. I would hope everything is safe on the shelves, correct? But Gretchen?
Thank you, Senator Pavley. And yeah, BPA is not something that is found in nature. It's not like lead or arsenic that could be in drinking water, or something that is going to be sitting on the walls where you touch it and all of a sudden you have BPA in your hands. It needs to be deliberately added in order to achieve the levels that we're talking about in the bill. So the assertion that somehow it could be floating around and ending up in a product is actually a little bit concerning to me, because that means, well, what else is getting in their product? If they think that BPA can contaminate it so easily, what else is contaminating it? One of the things that was also concerning with hearing the opposition's testimony about the alternatives and their claim that there are no alternatives on the market right now is that we were just on Nestle's website earlier today, and they brag about the fact that they have BPA-free baby food. Their formula containers do not contain bisphenol A, yet at the same time they're coming here and saying that they don't have alternatives that are BPA that don't contain BPA. So it seems to me that somebody's being misled here. Either they're deliberately misleading their consumers, or they're deliberately misleading us. And I'd like to know which it is.
I'm just wondering, does BPA free, does it mean that it's not been used as an additive in the creation of that container? Or does it mean that if tested, it would test below whatever limits you've established in this bill? And I think that is a distinction. I'm curious as to whether or not the levels that you propose in your legislation are achievable. Is there someone that can speak to that from the opposition?
I'm happy to try. I'm not a biologist or a chemist, but I'll do my best. Assemblymember Strickland, I think the issue here is this chemical is ubiquitous in society. It has been out there for 60 years, and it is out there. And in fact, I've got citations to two published studies, one in biomedical chromatography and one in the Journal of Chromatography, that show that the average breast milk that women secrete has 1 part per billion of BPA in it. That clearly wasn't added intentionally. That just happens to be out there. That's 10 times the amount that's authorized under this bill. So it actually is out there. It's absolutely out there. We're talking about testing levels that are so specific and so intense that you're going to find anything. When you talk about 1 part per billion, you're talking about a single drop from an eyedropper in the size of an Olympic pool. We're talking about 60 seconds in 2,000 years. Now we're doing this bill is doing 1/10 of those. So when you start testing down to those levels, you're going to find everything. You're going to find mercury, you're going to find lead, you're going to find all sorts of things, because we're all breathing things when we're making things in factories. When I put something on a truck, there are things, there's dust, there are all sorts of things there, and so it's out there everywhere. And so, no, we do not believe that you can test down to this level, and that it's reasonable to ask to do so.
I would like to just add on there that that 1 part per billion, it was based on FDA pre-market approval done in 1997. We used that, but once again, Chair Jones and Assemblymember Strickland, DTSC will have this full year, if not, and especially on the formula, 1.5 years to say, maybe that amount needs to be tweaked, maybe it needs to be done, maybe it needs to be clarified that you have to intentionally put it in the formula, not that it was somehow, airborne contaminant that got on the outside of the container. I mean, we know what the intent is here. The people intentionally using products, putting BPA laced products into these kinds of containers and are leaching into the formula.
So anyway, I still have some concerns, and I'm hoping that DTSC will be able to come to a quick and speedy resolution as to what these issues are. So thank you.
Mr. Emerson.
Thank you. Senator Pavley, do you have any evidence showing any level of BPA in children's formula?
I can respond to that, if that's okay.
Yeah.
The FDA has done an analysis. They went out and bought 25 samples of liquid formula in the metropolitan D.C. area and measured them for levels of BPA. The average level was around 2 parts per billion. And they also concluded that powdered formula was not going to be a source of exposure because the packaging was in cardboard with an aluminum lining. They didn't consider that to be any BPA would be in that packaging and don't think that it is a source of exposure to BPA. We also know that exposure happens from drinking out of a polycarbonate bottle. So while there might be BPA in breast milk, that's because our food is contaminated with BPA, and all of us are getting exposure by that way. But many of us, I know that when I was a breastfeeding mom and were working full-time, would pump my breast milk and feed it to my baby in a bottle. So babies will get additional dose of exposure from using a polycarbonate bottle.
So you can provide us with that FDA study?
Absolutely.
All right. And do you have peer-reviewed science that states that any level of BPA is harmful that is in formula this time?
I'm going to have them respond, but I know there's over 200 studies that have been peer reviewed on this subject, but I want to get an answer specifically to the formula question.
The FDA has considered infants the most highly exposed because of the exposure from formula and polycarbonate bottles. They are currently being chastised by their science review panel for concluding that those exposures were safe in children. They were told that their conclusions that it was there was an adequate margin of exposure were deemed to be inadequate because their conclusions were based on 2 studies that were funded by the industries which make bisphenol A. There are over 200 published studies showing that current levels of exposure have been associated with harm. And I might remind you that in a person, our circulating levels of hormones are in the parts per billion to the parts per trillion range. So a potent endocrine disrupting chemical like bisphenol A in the parts per billion range actually is a significant source of exposure. If you can think about a child going through puberty, that's parts per billion of hormones, which cause profound behavior changes as well as physical changes. So hormones can act in exceedingly small doses, as well as synthetic hormones like bisphenol A.
So the 200 peer-reviewed articles would be human studies?
We have mostly animal studies, but we do have some human studies, especially, I should clarify that we have non-human primate studies as well.
Okay. I would like to get the bibliography of the human studies, the peer-reviewed human studies, if I could also in addition to that. And I have a question of Mr. Topp. Seems to be some discrepancy between what Senator Pavley says and what he said in his testimony about the FDA timelines in terms of BPA. I'd like you both to respond on that.
Thank you, Assemblyman. Senator Pavley is absolutely right that there is no specific timeline that the FDA requires for or lays out in regulations in terms of when they will approve alternatives. What they tell us is that we must provide them sufficient data to allow them to approve the change. And their concern is that they want to make sure, as I said before, that the product and the container maintain their integrity over time. And so what they require us to do as a matter of practice is to put the product into the new container or the new product into the old container, and you sit it there. You test it out over time, and you make sure that at the 6-month interval, the 9-month interval, whatever intervals you want to do, up until the expiration of the shelf life, which for most of these products is 18 months or 2 years, you have that the product maintains its integrity and that the container maintains its integrity. You don't want the can rusting and falling into the product. You don't want any of the nutritional value of the product dissipating over time because of the chemical reaction with the container. And so what we do is we go through a process that requires where we put the new product onto the shelves, and we study it over time. We then take that data, we analyze it, present it to the FDA. The FDA then goes through a 90-day stop clock period where they look at it and see whether or not it's been approved or it is safe. So what the reality of that is that it takes us 2 to 3 years once we find an alternative to then get that approved by the FDA. And the FDA's perspective, just so you understand, is they believe this has been safe for 60 years. Their biggest fear when we talk to them is that they will, because of some political pressure, approve an alternative that isn't as safe as the existing situation. And that's their biggest nightmare, because they believe the product is safe as done, and they are scared to death that we're going to have another MTBE problem or something like that where you don't have a new safe alternative. And so that's the process that we go to, and that's why it takes 2 to 3 years typically.
A 20-second response. These are FDA-approved powder and liquid containers that are already available.
That are without BPA.
Correct.
Right.
According to their website.
Okay.
Right. Yeah.
So, Mr. Emerson.
Well, yeah, I'd like.
Just if I can just interject, so I have the order right, and so folks know how long the list is. I have Ms. Salas next, Mr. Fletcher, Mr. DeLeon, Ms. Hayashi, Mr. Hernandez. Oh wait, I'm on the next page, Mr. Adams. Mr. Emerson, the floor is yours, sir.
Thank you very much. Senator, do you know what the BPA level is in those two products right there?
Well, if I can respond, if you look on the website or if you call the customer service line of these companies, they will say that they do not contain bisphenol A. So I am led to believe that they do not contain bisphenol A, as I think most consumers would be led to believe by those statements on the website and the customer service line.
May not be in their packaging, but I'm wondering about the content. I was just asking that question. Mr. Pop, what do you know about those products, sir?
Mr. Chairman, I'll only speak to one. This product is an Abbott product, and I will tell you that my lawyers and scientists tell us that this product is coming off the shelves along with every other one that we have. We do not say anywhere on our website that our products are BPA-free, and we don't say it when people call into our offices.
Ms. Salas.
Thank you very much. That was precisely the question that I had. I was a little confused by the testimony here that the author was presenting your product as being advertised as being BPA-free. The question that I had was that it was mentioned that there's over 300 products that are listed online that a consumer can purchase for their infants that are BPA-free. Was that correct?
In just today's online search for Babies R Us, there were 388 items that are listed as BPA-free.
Okay, and within those...
And there's other companies as well that offer products.
Within the those products listed, would there be, in your list of the products that you want to have BPA-free, is there any product here that is unavailable online in an alternative? In other words, a bottle or a cup, a sippy cup that isn't available with the BPA-free alternative?
Not that I'm aware of.
So in every instance, a consumer could get each product that they needed for their baby.
It's whether online, correct. In all stores, no, because that's the purpose of this bill, is that that's available to women with young children throughout all our demographic communities.
Okay, and then Mr. Top, if you could please clarify for me, you just mentioned that that product is going to be pulled off the shelves. Why?
This product would not meet the criteria that's set forth in the statute.
But you said it was going to be pulled off the shelves now.
It would be illegal for us to have it on the shelves in California.
But you said that you were going to pull it, with or without this bill, you were going to pull it off the shelves.
No. If SB 797 passes, oh gosh, no, this is on the shelves now, and we think it's safe and a great product for consumers. And it will stay on the shelves if this bill does not pass. If this bill passes, then this product and all of our infant formula are coming off the shelves.
How about is a Good Start yours as well?
It is not.
That is not yours. Okay.
One of the points is Connecticut and Minnesota have already banned them. So do you take them off their shelves, but they're on our shelves? I mean.
Okay, and then I know that the opponents, when they originally spoke to me, one of the objections of the bill was that it was not necessary because the Green Chemistry Initiative was going to be implemented and in place, and so why not wait until that happens? And today we're seeing amendments where the deadline or the implementation of this now meets the time that the Green Chemistry Initiative will be up and running, and that whatever the Green Chemical Initiative determines, whether the BPA is safe for babies or not, then that's what stands, regardless of this bill.
With all due respect to the amendments that we just received, I think this 2 points I'd make. One, this actually does the green chemistry backwards. The entire concept of the Green Chemistry Initiative was that scientists were going to review the chemicals and determine what was safe or what's not. This says that the legislature has determined that this is unsafe, but the scientists can overrule them. The second point I'd commend the committee to is Congressman Henry Waxman is moving a bill, and we all know Congressman Waxman is certainly considered one of the strongest pro-consumer members of the legislature of Congress and has been for years. Congressman Waxman's food and safety legislation, which is currently moving in Washington, just had a provision amended into it, and what it did was it asked the FDA to yet again review BPA and its safety, and that none of us are objecting to that measure, but again, even Congressman Waxman is saying that we should have the scientists take a look at it, and that's exactly what we agree with as well.
Okay, and just one last thing. I just can't wrap my hands around this product being offered on a website that says it's safe. It doesn't say BPA free.
It does not say that it is BPA free. What we do say to our customers when they call is that our products are absolutely meet all of the requirements that are out there for every regulatory agency in the world in terms of safe levels of BPA, and that's exactly what it says, and that's exactly what we do.
Thank you.
Okay, Mr. Fletcher.
I wasn't here when the legislature heard chemistry bill after chemistry bill, and so, but
Neither was I.
Neither were you. Okay, but I have been told that the long, arduous fight to establish the green chemistry process was just an establishment so the legislators wouldn't be measuring parts per million and parts per billion and reading peer-reviewed journals and doing those types of things, because perhaps that's not the job of the legislature, is the job of the scientist. And so one of my concerns, and I'm open if I'm missing something, was that was put in place recently. And now, before that's even taken effect, the legislature is in essence going back to what it was meant not to do. And I understand the amendment, and I understand the process of saying, well, we're going to ban it unless you assess or tell us otherwise. But I guess my concern is, if we do it here, I don't know why we wouldn't be right back next year with 10 or 15 other chemical bills that we're now telling the Green Chemistry Council that they have to evaluate or rule on by a certain date. And I kind of feel that before the process has even started, we're kind of circumventing it and going to the heart of what it was established to do. And I'd be open to anything, any advice or suggestion you may have as far as if I'm missing something there.
If appropriate to respond on that, this time next year, their process should be up and running. I think that argument is moot. This particular bill, I've talked to the authors of the Green Chemistry Initiative, Simidian and Fuhr and Huffman. It was never intent to delay action on chemicals that we know cause harm. And that's why you're hearing sort of the dueling science, supposedly, although we feel the 200 studies make it very clear, and that's why other states are passing this ban. So what it does is say, okay, green chemistry, you promised you'd be up and running by the end of this year. The regs are coming out in August. Get up and running, because this is an important chemical. The public is concerned about it. It wouldn't have BPA-free containers in all the stores and online if there wasn't public demand and concern for exposure to this chemical. At the end of the day, it's 500,000 kids born every year in California. How much delay should we allow? So we're saying this, because the green chemistry process isn't up and running, this bill says, yes, it'll be banned, but not till 2011 or July of 2011 for the formula, giving DTSC very adequate time to review, to decide. They can change it, they can amend it, they can delay it, they can tweak the parts per billion. That's all in their power, but it sort of holds their feet to the fire, because I'm very concerned that a long delay is not in the best interests of our children, especially those yet unborn.
And like I said, I mean, this is not to the merits of the particular product or what's being discussed. I guess my concern is if the Green Chemistry Council, as it's established and set up as a process, can't evaluate a harmful product, if it's harmful, if it's not harmful, if it shouldn't be on the shelves, if it shouldn't be on the shelves, then maybe we shouldn't have it. I mean, maybe if it's the duty of the legislature to say this is harmful and this is not, then I guess I'm questioning why all the energy and effort went into creating it. And I understand what you're saying about pushing them and holding their feet to the fire. I'm a little bit concerned that coming in, it was like we spent years establishing the Green Chemistry Council to do this very thing so that we aren't debating parts per billion in Assembly Health Committee. And now I feel like before it's even started, we're kind of right back. So I understand where you're coming from. I just have some concerns that a lot of energy and effort went into setting up that process. So thank you, Senator.
Mr. De Leon.
Thank you, Mr. Chair. Senator Pavley, with regards to Measure SB 797, I am sympathetic to what you're attempting to do. I know there's a lot of diversity on this committee with regards to whether it's the green chemical initiative, or should we go piecemeal, one by one. There's a lot of diversity on this committee. My question is the following. I know we've discussed the bottles and the canisters and the jars. My only concern would be feeding tubes, or what the unintended consequences would be with regards to pediatric care. If the bill were to come to fruition, codified into law, and there is no other replacement for these types of tubes.
There is nothing in the bill on feeding tubes. It's specifically baby bottles or sippy cups, a jar or plastic bottle and that's, so feeding tubes by not listing is not in the bill.
Okay.
And that was brought up by one of the opponents.
Today, I'm getting here late, so I'm just, I got to hear what.
Not listed.
No concern at all whatsoever then. Okay. That was my only concern, was that the whole potential unintended consequence with pediatric care, and that's fine. Thank you, Mr. Chair.
Thank you, Mr. De Leon. Ms. Hayashi.
I think we had the same question, actually. Were you referring to medical devices?
Yes. Well, more so just pediatric
not
care.
In the bill.
Oh, okay, great. Thank you for the clarification.
Okay. Thank you. Mr. Hernandez.
I just would like to have a follow-up question or answered for Mr. Top. And you had mentioned when you had talked about the Similac, your product, that if this bill were to pass, it would be taken off the shelf immediately. Explain to me about the timing of finding an alternative if that were the case. Right. What kind of length of time is that going to occur, and the cost that occurs with a company like yours?
Thanks, Assemblyman. I think one of the things that I probably should have mentioned earlier in my discussion is that we are constantly looking for new ways to improve our packaging and improve the safety of it and the quality of it for our consumers. We certainly understand that there is concern out there amongst our consumers about BPA, so we're constantly working on this process. Because we don't make BPA and because this isn't our issue, I mean, it's not our problem, it's not our situation that we created. We have to work with the companies that manufacture the products, that manufacture the containers, the chemical companies that put together the epoxy resins that maintain the integrity integrity of the product. We go through that entire process, and we're constantly looking for alternatives. That process can take, once you find an alternative that you hope works, the testing process is 2, 3, 4 years if it works. And then if it doesn't work, if you find after 2 years that the product didn't maintain its integrity, then you've got to go back and you're back to the drawing board. So we're at a very long period of time, but we're constantly working on it.
Thank you. Can I just correct one thing, though? This bill does not require your company or any company to immediately remove products. It merely says that if by January 1st, 2011, DTSC is not acted, then there'll be a ban, number one. Number two, DTSC could act between now and January 1st, 2011 and say, you know what, we don't really think this is a problem, and so our regulation is going to be not to regulate, in which case that would supersede the ban. If for some reason they can't act within the year and a half from today's date, and oh, might I add, 2 years from the date that we adopted the Green Chemistry Initiative, and frankly, 2.5 years from when the, well, maybe 3 years from when the Green Chemistry Initiative was first conceived, they could still act after January 1st, 2011 to say, you know what, notwithstanding the fact that the ban went in place on January 1st, 2011, we've now decided, based on the science, and again, this is all based on the science, that that ban doesn't make sense, and that would supersede the ban. So the amendment, and I know not everyone's had a chance to look at it, and I apologize for that. I mean, that's one of the natures of the legislative process. But the amendment does vest in the scientists at DTSC the ultimate authority to decide whether or not a ban and what kind of ban makes sense. What the amendment does do is holds everyone's feet to the fire and say, consistent with the Green Chemistry Initiative, by 2011 for this particular chemical, you guys got to decide what you're going to do. All right, so Mr. Adams was next.
Thank you very much, Mr. Chairman. I understand the intent, at least I think I understand the intent of you, Senator, and I fully support the idea of moving forward with the idea of having DTSC review the question of BPA and make an informed scientific decision about this. But it does disconcert me to no great length that we're moving forward in a quasi-scientific environment as if we actually had any substantive human data to determine the degree to which this is actually harmful. And I can't help but be reminded of the 70s and the 80s when we had massive national debates about saccharin and about the great and horrifying crimes that saccharin was to be, committed upon us because lab rats were getting sick when they were being fed 2 pounds of the stuff. The reality is, though, I'm still eating my Sweet and Low, and I still think that at the end of the day, this is a question of tantamount scientific concern. And I think it belittles the question when we have these discussions as if we are scientists. The reality is sodium in and of itself is intrinsically dangerous at certain levels. Chloride is intrinsically dangerous at certain levels. But sodium chloride is table salt. And arguably, while it may give you hypertension and may cause some secondary problems, in moderation, there's nothing wrong with table salt. And I think that's fundamentally what I object to in the bill. If it is, in fact, your intent, the DTS review this, and that's the entire intent, then I don't think the remaining language needs to be in the bill. I think simple intent language would be sufficient, and for those reasons, I can't support the bill.
Mr. Perez.
Thank you, Mr. Chair. I want to commend the Senator for bringing this forth. Obviously, through your work here, we're trying to protect the most vulnerable, our babies, our children. And in this case, perhaps even our youth of color that are living in underserved communities and perhaps don't have the parents who have the resources to take care of them and go purchase items that perhaps they just can't afford. But I will say that I'm not a chemist, nor am I a biologist. And it's very difficult to make a decision on this issue because, quite frankly, I have received data from both our opponents as well as our supporters. Right? One claims that there's data that states that BPA is detrimental to our youth, and others claim that it's not. And for that reason, the Green Chemistry Initiative, which would consist of scientists was created, and I also share the same concerns as our Vice Chair, Mr. Fletcher, because I do believe that through this process there is a possibility that we could undermine their work and the work of many people to create this initiative. But I do appreciate the amendments that you are willing to take with this bill. And so today, I will vote a courtesy vote, and I will vote yes, but I am concerned as to how this may have a negative impact in the Green Chemistry Initiative. And I will ask that you continue to work with those that are the opponents of the bill. And so, as I mentioned, I will be voting yes today as a courtesy vote, and I do commend you for your work that you do on behalf of the most vulnerable.
Thank you.
Thank you, Mr. Perez. Ms. Carter.
Mr. Chair, my question was asked by Mr. De Leon and Ms. Hayashi, and was answered. Thank you, Senator.
And may I just say on that regarding the feeding tubes, which were, was it that the question? Medical devices and feeding. If we need to expressly put that in the bill, it's not one of the 4 things listed, but expressly put it in that it is not the intent that this be part of the ban, I'd be glad to do that.
Okay. All right. Any other questions from members? Well, I think everyone has asked a question. Mr. Nava has it. No, Mr. Nava. Don't
encourage
I'm so
him.
sorry.
It's too late. It's too late. Now you started it. No, but taking into consideration the amendments, and then Mr. Armiano, I'm sure, is going to want to say something. But taking into consideration the amendments, I mean, yeah, it really is time for us to vote, and so I'll move the bill. But I also think that there's a lesson we can learn here in the issue of workers' compensation, and if part of the value and the benefit of the bill is to make sure that we get the results that we're looking for from the organization that's supposed to be the Green Chemistry Initiative. Because if you talk to anybody that's involved in workers' compensation, there were regulations that were supposed to have been developed and promulgated that haven't been, because there's been no consequence as a failure to issue the regulations. And so injured workers still remain without the sort of structure and protection to which they are entitled. And so while someone may say that that's a stretch, I think if part of the initiative for this bill is to get the Green Chemistry Initiative to be initiating, then that's a good purpose. And I move the bill.
Motion from Mr. Nava. Is there a second? A second from Mr. Armiano. The motion is do pass as amended. Just to be clear about the amendments, there's the mock-up that was handed out by the committee. I heard the author say she'll take as an author's amendment and express statement that does not apply to medical devices.
Correct.
Okay. Appreciate the dialogue on that. And I think that's it. Would you like to close?
I appreciate the discussion. The reason I'm carrying this bill is on behalf of future children. I appreciate the chair's leadership in finding a way to allow DTSC to review the ban if it's needed, or modify it, or change it, or decide not to go forward. This pushes their agenda in high gear, which is the goal of all of us, and I ask for your aye vote.
Okay, and just to be crystal clear, there's also a technical amendment on page 9 of the analysis, and I understand you to be taking that as well.
Yes, absolutely.
All right. Let's call the roll.
Jones.
Aye.
Jones, aye. Fletcher?
No.
Fletcher, no. Adams? Adams, no. Amiano? Amiano, aye. Block? Carter? Carter, aye. Conway? Conway, no. De La Torre? De Leon? De Leon, aye. Emerson? No. Emerson, no. Gaines? No. Gaines, no. Hall? Hayashi? Hernandez? Lowenthal? Aye. Lowenthal, aye. Nava? Aye. Nava, aye. Perez? Aye. Perez, aye. Salas? Aye. Salas, aye. Strickland? No. Strickland, no.
So that is 8. It needs 2 more. measure is on call. Thank you, Senator.
Thank you.
Okay, we're going to call our last item, which is Senator Lowenthal's bill, and I'm going to step out to present to Senator Lowenthal's committee, which I hope is still going on. Perfect, perfect. Well, everybody, please treat Senator Lowenthal well. And I'm going to turn the chair over to Mr. Fletcher. And I know there's support on both sides for this incredibly important bill that Senator Lowenthal has. And I want to cast my aye vote right now for it.
Moved and seconded.
Senator, it's good to see you.
Good to see you, Mr.
All right.
Chair.
I know
Thank
nothing
you,
towards
Senator.
it.
We have a motion by Mr. Adams and a second by Mr. Gaines. Motion is to pass.
Well, thank you. I'll just be real brief. You know, I do accept the, just to be